0% chance of having a vessel injection if you're careful on it. Then you have this dynamic real time, where you have a dynamic imaging, and you really see when the pain comes. Patient tells you, okay, at this very moment, this very time, my pain comes. This is such a help. It is in the cervical area also to some extent. What Narose is beautifully said once, and it's really rightly said. The only ultrasound can truly prevent the complication with direct visualization, whereas fluoroscopy can detect only the complications when it has happened, when the accident has happened. So it's not telling you beforehand, it is telling you accident has happened. So we have to prevent the accidents instead of treating the complications. Now, the first and easy and straightforward thing is stellate ganglion block. I think people will get used to these ultrasound modalities, and very, very helpful tool for all people who want to begin with the practice. Ultrasound practice is one of the easy thing you can start doing it, and right thing, straightforward thing. This is you keep seeing a lot of vessels around, and if I know how we were doing all this stellate ganglion block, all these ages, put in needle straight there, push the trachea other side and carotid one side and get in there onto the bone and come out 2, 3, 4 millimeter and give your stellate ganglion block. How can? People used to do 15 stellate ganglion block every alternate day, so for about a month or so, and I must be, there many times the drug must be lying in the one of the muscles. God forbid if it goes into one of these vessels here, what can happen? So we have to very, very wary of these things now. More and more we have realized, using ultrasound, we realize how risky it is doing a blind work in here. So I would advocate everyone to pick up an ultrasound thing and just at least have a look at it, what you're doing. So that will give you more of courage doing more ultrasound guided work. Yes, one has to be really seeing that you have to inject only this area. You're not going to inject there. There's a phrenic nerve lying there. You're not going to inject close to this. There's a recurrent nerve lying there. So you have to be careful on those accounts. Now this is the we can go perpendicular straight forward, but it's much advisable and much wiser if we go from the sidewise and we go the lateral view, we go lateral approach into lateral approach, which is much wiser approach and much right approach. Now it's said this is longus colli muscle. Your LA has to be subfacial. Remember, this is the perivertebral fascia. It has to be subfacial, and that is where the your ganglion lies, sympathetic ganglion lies, and how accurate you have to be. So it's very, very important. And they did studies. They found when they put in a dye with the methylene blue and did a test injection on the cadaver studies, and they found that when they do it, it's in the subfacial way. You're just on the ganglion only. That's the rightmost place. And if you are over the fascia, you are nowhere touching the ganglion. So it's important to be subfacial. Now the target, how do we do it? Ultrasound should be in front of your eyes. This all should be in one line. Your eyes, your hand, your probe, and your screen. They all have to be in one line. Very, very important. Everybody has to study. If it lies one of this direction or the machine this side or patient other side, it is very disastrous. So one has to learn this technique rightly. Now this is where we just try to put in line. We try to go in line under the carotid. I'll show you the image now. And we just go in line. This is where the carotid artery is here. And this is where the stellate ganglion lies over the longus colli muscle. And we are coming from the sidewise and just putting our drug in there. You can manage with the lower volume. Remember, very, very important. Ultrasound gives us such an accuracy. Even 1/2 or 1/3 or 1/4 volume, you can manage the same block efficacy what we do blindly. And this is what the trajectory is all about. We are just seeing the things, how the trajectory is there. But always the idea of doing this picture is always put the Doppler on. You have many vessels around. You have vertebral artery, you have a vertebral vein, you have the interjugular, and you have to bypass all of them. Initially, we have to hybridize. It's like going from petrol car to electric car, and then we have a hybrid car. And so we have to kind of hybridize. We should have a fluoro unit. Always check with the fluoro initially. But with experience, you can manage without fluoro also. And have a look. Your dye has to go in front of the first rib where the actually stellate ganglion lies, ahead of the first rib. And that is what it is all about. This is a beautiful study which was done. They found if you just put 5 ml drug, your drug walks vertical in the next to the stellate ganglion sympathetic chain. But if you start putting 10 ml like people used to do it for 7, 8, 10 ml, it starts going horizontal. So once it's going horizontal in this area, it is going more in the collateral areas where it is more collateral damage, and it's going unwanted LA spread, we call it. So that is not advisable. So ultrasound is very, very helpful that way. Let's talk about cervical root map pains. we know it. We all know about the root map pains, where from it the pain is there, and there will be few cases where you initially have to do a either preoperatively or post-surgically or a failed surgery syndrome. You might have to do a root block, and it's a very helpful tool in such patients. It is very helping, I tell you, cervical root blocks. Yes, lately there is a very big risk of doing it the fluoro-guided, because a lot of vascular injections have been there, so it's almost banned or stopped world over. But yes, with the ultrasound coming in, it is really resurging again to some extent. But understanding the is important. Now this is what we are going to talk about. This is at the, we start with the V6. So what is the anterior tubercle is very bright and prominent is there at the V6, at the C6. This is Schegneck's tubercle, we all know it. We have been doing a stellate ganglion block over this. It's not advisable, it's a middle cervical ganglion, not the stellate, by the way. So we try to give it a C7. The C7, we have the posterior tubercle, the anterior tubercle is very rudimentary, but then you start seeing the vertebral artery also by the side of it. But you can really see beautifully the C7 root there. And if you go even further little laterally over the first rib, you can see the C8 root also, and that is where you sometimes you might have to go a C8 block. But about the if you start going a little upwards, then at the C5, both the tubercles, anterior and posterior tubercles, they are on almost same height, and it's like a catch sign. I call it as a ball catch sign. So it happens in there. And C4, C3, they're almost same. They start getting smaller, by the way. But this is called a double hump camel sign, typically speaking. And your nerve really jumps out of this, and that is what you're going to see in next few images. Now this is what it is. Anterior tubercle is really bright, and you really see it's shining, and you really see this is C6, and you see the root in there. This is a very good ultrasound image with a good machine, but yes, with practice you can manage to see this in all machines which you have with you. And this is the C7, which I just mentioned you a minute back. And this is the C5, the two anterior and posterior tubercles. If you very carefully watch, you see the festal pillar right there, roundish pillar. I'm going to talk more about this after some time. And this is what Nerozzi studied. When he started putting a Doppler, always you have this thing, put a Doppler or a power Doppler on, and you see the vessels in there, and you start seeing vessels. They found the vessels sometimes lying even in the foramina areas, and you have to be careful. You cannot be just blind, go in there and do your shot there. It can be disastrous sometime. And I'll give you the study after a minute. So this is how you're going to do it. The patient's head has to be turned slightly away. You can have a semi-decubitus position on the part of the patient, or you put something under the some pack under the shoulder also, and you go from side in line with the probe. And this here you see the posterior tubercle, you see the anterior tubercle, you see the nerve. You don't inject when the nerve is right there in the dip of the trough. You just see when the nerve jumps out of it here, and that's where you tend to give your injection. As soon as it jumps out of the tubercle, posterior tubercle, you take a needle up there and put there. Although it is a little extra foraminal, but said it's as good as the transforaminal injection in many ways. So it's good enough, and you're away from the vessels most of the time. But yes, you have to be careful. Put a Doppler on and see the things, and then you start putting. As soon as you put your drug, you should start seeing each drop of your drug spreading around, and then you really start seeing that is inflating, and you see the flow of the fluid. It should not happen that you put something and you're not seeing it. It should not happen anywhere in the ultrasound guidance. And never ever miss the tip of the needle. Never ever miss the tip of the needle, because your tip of the needle may be lying somewhere here if you are not looking at the shaft of the needle. So always have a focus on the tip of the needle through and through. And this is what the position is. You do it in lateral position, or I will tell you semi-decubitus position, and you have to come from posterior to anterior, and you just give posterior to the root there. You never come anterior to the root because there are many reasons. I'll just explain. And this is what I'm trying to say. Posterior tubercle, go and touch posterior tubercle. Fluoroscopic validation for your satisfaction. Over a period of time, you will stop doing it. But yes, there is no problem initially. In some few cases, you do combo thing, or in difficult cases, you combo it. And this is what it is. Your needle is coming from the side. You put in a dye. You see your dye is walking in and out. Even extraforaminal is good, I told you. It works sometimes as good as transforaminal injection in these situations. Now, what is recommendation? This says, this is beautiful lines I must read for you. 20% of the dissecting cervical foramina contains either deep or ascending cervical artery within 2 mm of the directed needle target for the procedure. These arteries were found to enter in the posterior foramina in 33% of times. Remember, please, you don't see beyond bones for the matter. It's all blind thereafter. and you don't see the medullary arteries. That's another very big worry. It's a smaller artery, so you have to be careful. Extraforaminal injection work as good as transforaminal spreads. The pulse is keep your very important point here. Transparent transducer perpendicular as you can scan, and to keep your desired vertebral level inside. If you angle your transducer, you may see a level above or below. Remember, if you just slightly angle it, you may see a level. So I always keep telling my assistant and other people or second person in the OT, if I'm just losing the sight, please keep a watch that I'm not losing the vertebra. Always inject from the posterior to anterior direction to avoid the internal jugular veins, vagus nerve, common carotid artery, and 80% of the time the anteriorly located radicular artery in the cervical foramina. And Doppler may be helpful to find the feeder vessels I told you, and if possible use a blunt needle if possible. This is one study just for the sake of interest. People are starting intradiscal injection PRP in regenerative medicine with ultrasound guidance. Okay, we've been doing fluoro, it's okay, you can do this. Now this is to do with the facet joint pain, and this is, we know it, this is the J line where the epidural target is there. This is the facet joint pain, and these are the joint pain maps. People will come, many of these patients will have a joint pain map. There are few approaches. Now I'm going to talk about the posterior joint approach, intra-articular. Then I'm going to talk about the lateral joint approach. And the idea is you start from above and you start seeing the C2, and when you start going downwards, start counting the spinous process and go sidewise. As soon as you go sidewise, keep your transducer in the corner, in the longitudinal plane, and you start seeing the sawtooth appearance, and you really know which level you are in. And once you know the level, you can inject the level accordingly. And this is what they've done. Panoramic view is there. And I give you one little guide. You can scan with the linear transducer, but as soon as you want to do a procedure, a curved transducer is better because you can see longer length of needle. And although there are some needle tracking devices also there, make use of those machines. They are very, very helpful. And you can really go right there in the posteriorly, you can go into the intra-articular, but don't go beyond. As soon as your tip touches the posterior joint capsule, you don't have to go beyond, because then it's blind. You may go anteriorly and it can be disastrous. Now this is about the facial nerve block. You just seeing, by the way, you're seeing the joint line here, lateral joint line in here, and this is the crest and trough, and the crest is where the joint is there, trough is where the nerve is there. And this is when you're going from sidewise, you can really do the injection this way also. People have liking for this, and I always say have a M line of your transducer, which is the middle line, put it right there in this image, in the middle of the image, and you take a needle just by the side of the transducer, get in there. A very, very helpful tool for superficial injections, and you can get into the joint there and can give injection. This is about the intra-articular. Now we're going to talk about the facial nerve anatomy. There's a change in the philosophy now, and understand this philosophy, very, very important. This image was very important. I thought I must share with you that the nerves, they don't come like obliquely, like we have been talking ages, go and oblique. They have been going more straightish, or more horizontal, in other words. And even if you put a probe in there. But my guide to all my students and everybody who's there, that your stim is your best guide if you're doing an RF. If you're doing just injection, joint injection, it's a different thing. Facial nerve injection is a different thing. But if you're doing an RF, put your stim on and your stim tells you everything. You don't have to really think much about it. Now how do we do it? Mastoid, go backwards, slightly backwards about a centimeter or two, and start piling down. As soon as you go down, you first see the C2-3 joint space. And at the C2-3 joint space, there is a third occipital nerve, TON. I'll show you a few images, beautiful images after this. And this is the crest and trough. You start seeing the C3 median branch and then C3-4 joint. And this, you start going a little further downwards. You can really count your levels, And you can really come, and C6 is there. C6 joint cleft is there. If you want to see C7, you just have to go slightly interior at C6-7 level. And then you start seeing the TP of C7, which is little up there, and uphill is the nerve, which is C7 nerve lies little uphill there. So you can start counting from C2-3, or you can start counting from below. It's always customary to start counting from C2-3 and go there, and you can really reconfirm, find your 4, 5, 5, 6 and 6, 7 level, which is more often there, positive there. This is what I was talking about. Your C7 median branch is going upscale when you're going uphill for the TP, C7, this is where the C7 median branch lies. Go and do your RF there, stim, and then you're really fine. One important observation is there. You see few of these halos there, and they are not, all are not nerves, So put a Doppler on. Sometimes you find vessels there. So be very careful when you have a vessel. You are not supposed to inject inside the vessel your LA or anything there for that matter. It's a waste and it is deleterious also. So careful on that account. And that is how we do it. We go from anterior to posterior for C7 festoral block. Anterior to posterior because you are avoiding going from posterior to anterior, because then you have all those structures coming in. I'll give you a lead. Go and sit on the bone. Have a touch on the bone first. Once you touch the bone, you put your drug in there and you should see your LA. You don't have to put much. 1 or 2 ml is more than enough. You don't have to put much of LA, because then it's going to go to the root. Some people say you even 0.3 ml LA is more than enough for this festoral nerve diagnostic block. Or you can do a therapeutic block if you want. And going from posterior to anterior is dangerous, I mentioned you, because you have anterior vertebral artery and other major structures, or root for that matter. That is not advisable. I just gave you a word of caution. That is how I try to see this. Now this is the Korean method. They see in a coronal longitudinal axis and they go in plane and they put a needle in there and they sit in the groove in there and do your injection. In this way you can do multiple places. For this joint you have to do a block here, block up there. And like for 2 joints you do a block here and block there. So they do multiple blocks with a single needle, entry needle, and they can do this. This is a Korean method. Yes, it's very much doable, and with practice you can do more and more of this. Now I'm going to talk about the RF now quickly, and this is the RF. We just try to find the level where you want to do an RF. Put in the middle of the probe, right there I mentioned you, M line I told you. Take this, the M line, this is the middle of the line, and then you take your, find the depth, you have about centimeter depth, go a centimeter back, downwards, and then you start going inside. Now your needle will be shining up here for that matter in the cross section, but this is now, once we enter the needle, you immediately come in the parallel to the needle now you do a short axis view. Now you have this long axis of the needle for that matter. Then you start seeing the thing that your needle is walking in like this. You'll see few images. By the way, this is the festoral pillar, this is the posterior tubercle, this is the anterior tubercle, and you have the nerve lying in there. And your posterior tubercle or posterior, this is very, very safeguarding this. Until you over jealously push your needle in there, it won't happen. And this is where you want to sit in there. This is a posterior tubercle. You really have to sit in here. Do your RF. You can really see your nerve is lying there. You put in LA and you do your RF. You can do very well do your RF. This is very, very helpful technique. All those things. And this is the 3D reconstruction. You have the nerve, posterior tubercle, anterior tubercle, festoral pillar, laminas, and the spinous process. Yes, fluoroscope validation. Yes, if you want. Yes, go ahead, do it. Till now the practice is always do a fluoroscope validation for the RF. For LA, festoral nerve and LA intra-articular, you can do it. But when you do RF, you do a fluoroscope validation. This is still the practice. Yes, one can choose to jump to full fluor ultrasound guidance if you want later on once expertise. This is, some people want to do cryoanalgesia. It's a very, very good technique. If you don't want to do an RF, you can do a cryoanalgesia. Same thing, needle, and it's a different energy source. Now I'm going to talk about a cervical trigeminal complex. We do have this third occipital and greater occipital nerves, and they come and give a problem. So I'll just quickly go, and this is what about the C2 is there. You must see the Doppler on. You first see the vertebral artery in there, and then you start seeing the C2 3 joints in there, and this is where the third occipital nerve would be lying, and you just start seeing in there like this. This third occipital nerve, and this is the median branch, and this is where you have to block for third occipital nerve. I'll show you a few images. This is where the third occipital nerve, the C2 3 joint. You don't miss on these things. And then you have the festoral nerve in there. If you want to do festoral nerve, you can do in there. And I'll tell you where we do with the RF and the block. Here we do in the ultrasound guidance, we do in a longitudinal axis like this, in a lateral patient in the lateral position, and you go from above and go there. Don't go from below up, because then you might just get in the vertebral artery or more ominous structures there. So you go from above down and just go and touch a bone. Bone is your friend here now. You touch a bone and do your block. But if you have to do an RF, yes, classical method is there. You have a C2 3 joint, and you know the lines where you have to be sitting right from the groove to the SAP, and that is where your nerve is there. And you put your probes parallel to this, and you can do with one needle. But I would like to combine and supplement, if you have to do combo procedure also, I would like to put ultrasound probe and check. I really see the nerve there, so I don't have to put 3 needles. Why we used to do 3 needles? We never knew where the nerve is there, and nerve is very large in size, so we used to do 3 RFs. This is about the occipital nerve, GON. So this beautiful image is there. You have the C2 bifid spinous process, and you have the G1 nerve there. Semispinal capitis, splenius capitis muscles are there. The IOCM is muscle is there. And this is where you have the, you really see it so beautifully if you put a probe in right thing. The probe, one end of it should be in the C2 spinous process, and the other end should be at the C1 arch. And this is how the muscle is obliquely placed, and you just see the cross section of this is a cross section of the nerve, and you see it beautifully. You don't miss on this nerve. If you start practicing, it's a beautiful way. I would never do it blind now. Sometimes the nerve can be bifid or trifid like this, and you really have to see, but always do a Doppler. It may be vessel sometime, and then how you do it. I go from above below. I don't come from below above, because then you might, if you surpass, you might get into the foramen magnum. So we have to be careful. Going above below is a little safer, and you just go. And always measure your depth. This is your depth. Your needle should not go beyond this, and you should be seeing your tip of your needle. This is the outer plane approach. But yes, for some reason, if I have to do a hydrodissection, I have a beautiful image. I'll show you, and this is how it will show. Hello around the nerve. This is how it will show. And once you have to do a hydrodissection, you just do a perpendicular image. Just turn your probe 90 degree. Instead of now going like this, it is going this way. Just see this. This is medial, this is lateral now. You see the beautifully the nerve, G1 nerve, and you can do hydrodissection. You go from the side lateral, or you can come from the medially. You can do hydrodissection, and this is coming from medially to lateral. So when you go medial lateral, you can do hydrodissection here. Lateral medial, hydrodissection here. When you go lateral medial, more careful not to go into the canal. And medial to lateral, more careful not to get into the vertebral artery. So this is what it is. But for hydrodissection, this is the best way. I would still advocate many people, if you want to do a neuromodulation technique, they can really see what plane they have to be in. They can really see the nerves also. And this is very, very helpful tool for a positive results. Many people failed these procedures because they were not in the right plane, and they have to use extra energy, and then there is to be muscle pain and muscle twitches there, which is not good. So people have failed for that reason. Many times they expanded the leads also. This is about the AAAO, just few leads, few points in here. And this is where you have to do a block for C0, C1, and this we do a block for C1, C2. Because the anatomy of the vertebral artery. Remember, but the vertebral artery is not your friend. It has very tortuous path and very anomalous paths at times. So your Doppler is a very, very helpful tool for the matter. Look at this beautiful image. Such a training, such a learning image in there. You have this C1, C2 joint in there, and your C2 nerve lies, just DRG just lies behind this. Just imagine this is it. And such a beautiful image. But if you have to do a block here, you do a block here because vertebral artery is going here. But if you have to do a C0, C1 block, you block in here, this C0, C1 joint. You don't block more medially because the vertebral artery is there. I told you it may be tortuous, so always good to go here. And it's always good to go at the center of the joint in here, instead of medially is the cord and laterally is the vertebral artery. And that is what you really try to see. This is where you're trying to be in place. There is the DRG. If you want to just do a C2 block, you can come and do it at the DRG level. And these are anatomies you should be very careful. It's not unusual. I do see C0, C1, C1, C2 arthritis. Occipital headaches, very, very helpful. Very useful tool. And you go from the side, put your needle in there, put in a dye, and then you just do your block in here. But have to practice safe. These are high-end blocks. I want people to be expertise. Yes, it can be started doing with ultrasound guidance. I would only say the faculty in the team can manage to, because others will really have to learn it well. Only then they can start thinking of doing this ultrasound guidance. Blood fluoroscope validation is required if you really want to do it. This is Nerozzi's films, by the way. Professor Nerozzi, he is the master, he can do it. Another important thing is C2 nerve block. Helpful for cervicogenic headaches. Very, very helpful. And you can do a C2 nerve block if you want to. And this is the picture for that reason. Last few slides about the trigeminal now, because the things are changing. Now, when you have the, this is called cervicotrigeminal complex. When you have trigeminal pain, people have a neck pain. When you have a neck pain, people have a frontal headache. So this all is known. This circuitry is already discovered, and it's actual neural circuitry. It's not just words. We stimulate here, there's a pain in there in meninges, and we even stimulate right in front, and there is a pain in the lower neck, and this is there. And this is the few pictures, which is, I think this is a changing thing. Now this is about the, we have the herpetic neuralgias and pain coming. We can do peripheral trigeminal blocks. in one line. This all is the line. You do the supraorbital, supraorbital, you do infraorbital, you do mental nerve blocks, and you just see the things in there. Go from below up. Don't come from above below, because the eye is there, and this is what you see. Sometimes you see the groove and the nerve both, and you can just go and sit on this thing. This is the infraorbital. You really see the infraorbital groove. You can really get into there, and you can get into sphenopalatine fissure and do your block there, like we do through Gerardo palatine foramina. And this is about the mental nerve. Helpful tool, is satisfying. If you really see, you see the nerve, and you really see vessels also. Sometimes is helpful. Another important thing is, people have started already doing infrazygomatic trigeminal blocks. You can really see beautiful the maxillary vessels there, and you go just deeper to that, and you deposit your drug with this for the sphenopalatine fissure blocks, for sphenopalatine ganglion or the maxillary nerve, which is helpful. So the idea is, then you can do these blocks ultrasound way also initially, but you do a fluoro ultrasound hybridization initially, and later on you can start doing it ultrasound way. And but yes, advised is you should start practicing from the other structures, other body structures first, and once you expertise yourself, then you can really jump on to the cervical. But I really find it very, very helpful in these scenarios, and I advocate my friends to learn it well, do it well, start from expertise, trigger points, and come to the neck, and you'll find it is very, very useful tool for that matter. Yes, I have been saying, do a combo initially, and then later on you can really jump onto the other things. Any questions will be more than welcome. I know I had to talk two things together, the neck and the head, that's why it took a little longer. So thanks my friends, thanks Dr. Krishna, thanks to the society, and thanks to other my faculty friends for bearing with me. Thank you so much, friends. Thank you so much.
Thank you,
Thank
Dr.
you,
Jain.
sir. Thank you, Dr. Jai. If there are any question, the participants can ask right now on head and neck block.
Anything you want, we can talk. We can talk.
Or if anyone have the question, we can talk later on also.
Anytime, I'm on through and through the whole conference. Anybody can come with any question sooner or later. We can talk.
Yeah. Thank
we
you.
can talk.
I just want to ask, someone asked in occipital hydrodissection, how much volume you give?
No, you're really seeing the volume. When you're injecting, you're seeing the nerve inflating. There's the nerve is all the drug is going all around the nerve, and you can really look, because many times it's an entrapment neuropathy, or the it's a very nasty neuropathy. People have pain for ages together. Like, and even for headache, you can do this block. It is such a helpful block for even for headaches. You should practice. You get many patients of headache coming to you. Put your probe there, put your needle there, and do the hydrodissection, and it really gives a very, very good relief to these patients. So we have to understand, like all tunnel syndromes, this is another kind of entrapment neuropathy. You can really do a hydrodissection, and at the end of it, put your LA with the steroid, and there is a job done. Where there may be some situation where you might do an RF, although to be avoided. I have done RF in few patients, but yes, hydrodissection normally is more than enough. But you really have a satisfaction of seeing the nerve opening up through and through when you go in length of the nerve. That's the whole idea.
What about the hairs, scalp hairs? What you do?
No, you have to really clean it well. Either you shave it or you have to clean it well. Obviously, you can't take chances. Obviously, that is doable. This should not be an issue. When you do C0, C1, C1, C2 block, you don't shave all patients for that matter. You just do it, clean it well.
You have to shave.
Yeah, yes. For occipital stimulation, you have to. Obviously, you have to.
Thank you.
Yeah, so, my pleasure. Okay. My pleasure, friends.
Everyone is praising. It's a fantastic lecture.
Thank you.
So,
Navalny,
now you can invite the second speaker.
Okay, madam. Our next speaker is Dr. Rajendra Sahu. Dr. Rajendra Sahu once upon a time was in West Bengal, but now he has shifted to KIMS Bhubaneswar. He is also very well-known pain physician. So without delaying, I am directly asking Dr. Rajendra Sahu to start his topic on pelvic ultrasound and interventions.
Hello, good evening. Thank you, Dr. Ray and Dr. Poddar, for inviting me, and thanks for organizing this one, this webinar in a short notice. Thanks, Dr. Neeraj Jain, sir, for the wonderful presentation covering so many things in a short point of time and giving all nice information to all the participants. So I'm going to talk about the pelvis ultrasound in next 20-25 minutes. So it is a difficult one to cover so many things in such a short span of time. There are few videos as well. Okay, so without wasting much of time, I don't have any conflict of interest, no financial support from anybody. So I'm going to talk about a few things here. In my presentation, I'll talk about the piriformis, gluteal muscles, pudendal nerve block, the caudal epidural, SIJ, how ultrasound can help us. Of course, because of the limitation in the time, I'm not going to talk about the inferior clonial nerve, which is also a common much of time, kind of rather misdiagnosed kind of entity, kind of new entity for the gluteal. So I'm going to talk about a few things here. About other things like internal pudendal sacropelvic impingement syndrome. So these are the few things that I have highlighted. I'm going to talk. Okay, so let us talk about the gluteal things. So it's a very complex thing in the buttock area. So it is important to know the anatomy very well before going to the sonoanatomy part. So here are the different muscles. One can see the big muscle here in the buttock is the gluteus maximus that originates from here. This is the iliac crest, just behind the posterior gluteal line here from the SI joint, from the sacrotuberous ligament. That is, once this is reflected, this part has been taken out. Just below that is the gluteus medius, okay, that originates between the posterior gluteal line and the anterior gluteal line. Okay, this is the gluteus medius and gets inserted to over here at the greater trochanter. The gluteus maximus, 3/4 of it gets inserted to the IT band. Then subsequently, once this is reflected, this is the gluteus minimus. Okay, so that origins between the anterior gluteal line and the inferior gluteal line. So this is gluteus minimus that gets inserted again into the GT, greater trochanter, but over to the anterior part of the greater trochanter. This just to give an idea how the different muscles are arranged. This is the tensor fasciae lata, another muscle from the anterior part of the iliac crest, between the iliac crest and the iliac tubercle there. Okay, that continues over here as the IT band, below which is the gluteus medius tendon. Okay, so this is how, this is the gluteus maximus getting inserted to the IT band. This is the iliotibial tract here, and this is the tensor fasciae lata muscle that continues as the IT band. Just behind that is the gluteus medius, and further below is the gluteus minimus. Okay, so once this has been taken out, the IT band over here, one can see this is the bursa. So there are many bursae over here. The commonest bursa is the subgluteus maximus bursa, or the bursa that commonly get inflamed or kind of affected in patients with lateral hip pain or over the greater trochanteric pain syndrome. Okay, once so this is how, once the bursa has been taken out, this is the gluteus medius muscle tendon getting inserted over here lateral facet, and that is the gluteus minimus muscle getting inserted to the anterior facet of the GT. Okay, these are all to give an overview how these different muscles are arranged, originating and getting inserted at the different places of the trochanter. Okay, and they have their implication while doing the sonoanatomy scanning and doing the interventions. Once the superficial muscles has been taken out, this is gluteus maximus, medius, this is minimus. Okay, and there is the insertion of those muscles. These are all deep gluteal muscles. Okay, commonly there are few of them like piriformis, which occupies the greater sciatic foramen here, and then again superior inferior gemellus, this is obstetric internus, quadratus femoris. These are all called external rotators of the hip, and they are basically can be strong pain generators as well. Okay, so moving ahead to the pelvic area and the myofascial pain. So we talk about, everybody talk about the piriformis syndrome. Is it a right terminology? Like, the things have changed in last few years. This is rather called a deep gluteal syndrome. One can see here so many muscles in vicinity of each other, piriformis, gluteus medius minimus, this obturator, gemelli group. So this is really, it's not fair to tell that it is the piriformis as the only culprit. So deep gluteal syndrome is basically an underdiagnosed entity characterized by pain and dysesthesia in the buttock, which sometimes can radiate to the posterior thigh or even in the radicular manner, which happens because of the non-discogenic sciatic nerve compression in the subgluteal space. So it can happen from either from the piriformis, gemellus, obturator complex, quadratus femoris, or kind of gluteal. So it is, the best terminology is a deep gluteal syndrome, out of which these are kind of entities, sub-entities. Okay, so here these are the muscles, and then again arrangement of all those deep muscles to show how they are closely related with relationship to the sciatic nerve, and each of them even can contribute to the gluteal pain, which sometimes can radiate to the posterior thigh and even to the leg as well. So piriformis again, one can see that originates from the S234 and gets inserted to the greater trochanter there. So this is the line where the patient may complain of pain. Okay, pain in the gluteal area and getting aggravated more while sitting. And then it can sometimes go down the thigh as well. Some of the tests were BT pace test, but they're pretty much non-specific, with hardly like 40-50% of kind of sensitivity for the diagnosis. So the best way is kind of a clinical test followed by diagnostic injection. So this is the piriformis muscle inserting to the trochanter over here. Okay, the piriformis muscle, so this is the greater sciatic nerve, this is the ischial spine over here, the sacrospinous ligament attaches to this one, the sacrospinous ligament attaches, that becomes the greater sciatic foramen. Whole of the greater sciatic foramen is occupied by the piriformis muscle. One can see just inferior to the, deep or posterior to the piriformis, anterior to piriformis is the sciatic nerve, and its close relationship to the other nerve and blood vessels. On the top of it is the superior gluteal nerve and blood vessel, inferior to the inferior gluteal blood vessel, and further medial one can see this is the pudendal artery. So this is really vascular. Okay, so one has to keep in mind the blood vessels and the surrounding nerves in this area. So this is gluteus maximus, big muscle, and once that has been taken out, you can see the piriformis there. Okay. So coming to the next, there is always this anatomic variation which can contribute to the pain. Okay, in 84% of the individuals, this is the normal pattern. You know, the piriform, the sciatic nerve, the single nerve goes further deep to the piriformis muscle, whereas these are all variations, and one of the commonest is the nerve dividing into two branches, the tibial and the common peroneal are the two branches there, and going through the bulk of the muscle. Okay, rest other are kind of very uncommon, wrapping around, kind of wrapping around, going through and wrapping around, or kind of traversing on the top of it. So ultrasound definitely can help in if careful ultrasound is being done, sometimes can help in kind of finding identifying these anomalies also. So this is moving ahead, how to scan on different areas. This may look complicated, but if you kind of are very thorough with the anatomy and the muscles, this is the gluteus maximus, big muscle that cover whole of the buttock, that has been reflected. Okay, this is the piriformis from obliquely oriented whole of the greater sciatic foramen. So this is the gluteus medius, this is the gluteus minimus, piriformis, this is the gluteus medius. Okay. Sorry, this is medius and this is minimus, I guess. Okay, the piriformis, then this is the quadratus femoris, this obstetric internus and gemellus are kind of intermingling in between. So first scanning technique, you put a probe over here and then come down over here and subsequently. Okay, so let us see. So this is a gluteal scanning video. I have done that in a volunteer. I think this is a 3 minute. I request all of you to hear it very carefully. This is a stepwise scanning technique that I do for all my gluteal scanning things, for a piriformis, for the obstetric internus, pudendal, everything. Okay, have a look. So this is the probe position, like we do the injections. Many people subsequently ask where the probe is exactly positioned. So this is the probe position, and the next video is about the sonoanatomy, how things look in this similar manner. Okay, listen to it and let's.
So I have to start my probe, and you can see the orientation marker is directed, and after I will put the probe.
Dr. Sahu, you can talk. We can't hear on the video. You can talk.
Oh, okay. Okay, let me do this. No, you should be able to hear it. Yeah. Okay, now you should be able to hear. Let me go back. You should be able to hear now.
So this is the PSIS, posterior superior iliac spine. So I always start my probe, and you can see this is the orientation marker. Orientation marker is directed laterally. I always put my probe over the PSIS and then PSIS, and then slowly start sliding down. So there you can see all these 3 gluteal muscles, and in the sonoanatomy you can see the gluteal muscles, then the iliac crest, the hyperechoic bony shadow in the ultrasound beam. Slowly start scanning in that plane itself, okay, in the transverse plane, and As I start scanning down, when I reach that superior part of the greater sciatic notch, okay, I can see the gap there in the bone, slightly come down, and then what I do, I go a little lateral, tilt the probe obliquely to orient in the direction of the piriformis and look in. Okay, and with that, so the piriformis muscle is seen in the screen. So what I do, this is the movement. Okay, in and out. You can flex the knee and do internal and external rotation to identify the piriformis muscle. The gluteus maximus is on the top and the piriformis is down. Okay, so I'm putting some color over here to show you the blood vessels. So that is the infrapiriformis and suprapiriformis blood vessels. So here, so for gluteus, for piriformis injection, my needle comes from medial to lateral. I put my needle around 2 centimeter away, heel toe maneuver, so that my needle comes from here to here, going to the bulk of the muscle. So here what you see, that is the parasacral plexus or the sciatic nerve plexus. You can see these blood vessels, that is the inferior gluteal blood vessels. Okay, and then once this part is done, what I do, I go slowly down, perfect. Now I reach at the level of ischial spine. This is the ischial spine, and then this lower is the ligament, that is the sacrospinous ligament. You can see the continued line. This is lateral, this is medial. Gluteus maximus, this hyperechoic line, that is sacrotuberous, and this is the sacrospinous ligament. Let me put some color over here. Okay, so lot of artifact, but that is more or less, that is your internal pudendal artery. So the needle comes like this in plane. You can see the pulsating artery, and this is where the target is for the pudendal nerve block between two ligamentous plane over here, again coming from medial to lateral. Have a look here. Now as I go off with the sciatic notch coming over, you can see the sacrospinous ligament, sacrotuberous ligament going down. Again the ligament is all gone. So that is the most important part. Now the lower part, what you can see, this is again ischial tuberosity, and that is the muscle, that is the muscle obstetric internus. Further going down, you can see the left end sciatic nerve over there, sciatic nerve, and just below that squarenus femoris.
Okay, so so that was the demonstration in a volunteer, how to scan stepwise. The idea is once you reach the superior part of the greater sciatic notch, okay, let me just go back because this is something many people, okay, see here for the piriformis. Okay, see how the piriformis is obliquely oriented. So I just come out in the transverse plane. Once I reach here, as I see the superior part of the greater sciatic notch, so what I do, I tilt my probe a little laterally, orient little obliquely in the direction of the piriformis, and tilt my probe into the pelvis. That is called heel toe maneuver. That way, that helps me visualize the bulk of the muscle. If I don't do that, I see kind of this bit of lateral tendinous part of the piriformis. So these three things, moving lateral, obliquely, and looking into the pelvis, that helps me in visualizing the bulk of the piriformis. And when I do the needling, I try to see the most of my needle. That helps in the visualization of the needle because of the deeper block. Okay, so you saw that video in a volunteer. Now please appreciate how things look like. You saw part of that sonoanatomy. Look here. Okay, so this is SIS, and this is muscles, gluteus maximus medius, and this is the hyperechoic ilium. As I reach this is the superior part of the greater sciatic notch. Okay, I do all those maneuvers in the pro positioning, then move the hip here with external rotation. That is the piriformis muscle, gluteus maximus, piriformis, and this is the sciatic nerve. Okay, as I go down, this is the ischial spine that becomes straight, flattened hyperechoic line, and then medially this will continue. This continues. So that is the sacrospinous ligament. Okay, this is sacrospinous maximus. This is the subtuberous, this is superior gemellus muscle, the sciatic nerve over here. Okay, make sure this sciatic nerve over here, and one can see couple of pulsation there. Make sure that you identify the internal pudendal artery pulsation. Okay, just to give an idea, these are the various things, this is my probe position. This is going to medial lateral, a high low frequency curvilinear probe, and I'm at the greater sciatic foramen piriformis, and then this is the sciatic nerve. Okay, piriformis. For a needling, the needle comes from medial to lateral. I reach at the bulk of the muscle, do a piriformis injection, local anesthetic plus minus steroid, Botox, or whatever you want to do. Okay, so in the lower part. So coming to how a piriformis injection is done, again, you first scan over here, PSIS, as I told you, PSIS and sloping ileum, then go down here at the piriformis, tilt little obliquely, laterally, look into the pelvis, and this is what you see, bulk of the muscle. Okay, so instead of doing very next to the probe, what I suggest, always go away from the probe, 2 or 3 centimeters away from the probe, and you will better visualize the needle tip with a bit of heel to maneuver also. Okay, because the deep block in some of the patients with big buttock, it has to be 4, 5, some 7, 8 centimeter deep also. Okay, so this is what you see, piriformis muscle again with movement and the blood vessels. These are all inferior gluteal blood vessels normal. So when you go, one has to be very careful that you do not damage the nerve or do not go further deep. You'll be inside the pelvis, okay, and you'll be inside the pelvis and the rectum. So that carefulness has to be there. Okay, have a look at this video. This is the gluteus maximus. This is the small piriformis, the sciatic nerve. One can see the movement over there is the rectum there, and this is the needle visualization. See needle and spread of the medication there. Okay, so that is the bulk of the piriformis muscle. Okay, so this is pelvis, sciatic. So little bit of inattentiveness and not able to find the needle tip can land a person into a sciatic nerve block, and even deeper. See here, deeper into the pelvis. See how it's spreading nicely inside the piriformis. Okay, this is the gluteus maximus there. Okay, so there is no way the drug is spreading to the sciatic nerve, neither deeper into the pelvic structures. Okay. Okay, so moving ahead, next one is going to be pudendal neuralgia. So it's basically pelvic pain in the distribution of the pudendal nerve that supplies the perineum, okay, around the vulva, vagina, anus, rectum, and the scrotum, okay, some of the penile areas also. So that is innervated by the pudendal nerve. So there is a criteria, it's a Nantes criteria, basically pain in the anatomical territory. So worsened by sitting. Okay, because pudendal nerve, we'll see that in the subsequent slides, it travels, once it comes out of the foramen, greater sciatic foramen, and then it travels between the sacrospinous and the sacrotuberous ligament and further goes into the Alcock's canal. It gets entrapped further while sitting in that position. So this is one of the criteria, pain getting worsened by sitting. Once person stands up, it gets better to beginning. Whenever pain becomes chronic, even some kind of dull-aching pain may remain while remaining standing position also. Then not woken up at pain by at night by pain. There should not be any sensory loss, and then positive response to a diagnostic block. So these are all diagnostic criteria for a pudendal neuralgia. Okay, so this is how, have a look. It comes from the S234. Okay, travels from the, once it leaves the greater sciatic foramen, enters into the interligamentous, the sacrospinous, the sacrotuberous. In that ligamentous plane it goes, and then subsequently winds medially to travel over the obstetric internus in the Alcock's canal. That is just a duplication of the obstetric internus fascia there. Okay, and divides into branches. Okay, one is inferior anal or the inferior rectal nerve, and then these are all perineal nerve, and the third one is the dorsal nerve of penis or clitoris. Okay, so these are the 3 branches of the pudendal nerve. Okay, so have a look. So this is in close relationship with the ischial spine. This is the medial sciatic nerve between the sacrospinous and the sacrotuberous ligament. See how they're related. Once it comes out of the greater sciatic foramen, winds up further medially, enters the lesser sciatic foramen, pelvis, and on this sacrococcygeus levatoroni, and supplies the perineal muscles. Okay, it's a mixed nerve. So again, these are all 3 branches. Okay, so this is again just to show you how they're interrelated. The scanning technique is again the same. Always start with top to bottom so that systematic scanning, you don't miss anything. PSIS, you look for the gluteus maximus, medius, minimus, greater sciatic. Once you reach the greater sciatic foramen, piriformis, go down. I have already said. See, for the straightening of the ischial spine, it becomes straight hyperechoic line, and look medially so that it continues at hyperechoic line. That means at this level, the sacrospinous ligament attaches. So a hyperechoic reflection occurs medially, okay, which was absent little cephalad or will absent when you scan a little caudad. So that point it continues at hyperechoic line. So it's sacrospinous, gluteus maximus, sacrotuberous just below that, okay, and in that interligamentous plane is you go. Okay, here is the just to show you this piriformis. Look here, scanning down, this is becoming hyperechoic straight line, and then medially it's continuous hyperechoic line. So that is the sacrospinous. As you scan up or down, it is not there continuing. So that is the point you should do the injection. Okay, here is a video showing gluteus maximus, sacrotuberous, ischial spine, sacrospinous ligament, medial to lateral. See how far 2 or 3 centimeter lateral needle is. So this is the nerve. Okay, that is pudendal artery here. That is the nerve. That is my needle tip. This is a 22 gauge spine needle. You can see the local anesthetic spread. Do the injection very slowly. If you do it rapidly, the sciatic nerve lies further lateral in the vicinity on the surface of the superior gemellus. It will just spread and can block the sciatic nerve also. Okay, do slow injection. 2 to 4 ml of local anesthetic is more than enough, and some steroid. Okay, so just to rephrase, here is how you look for bony contour at the PSIS level, maximus medius, like a downsloping. As you reach the greater sciatic nerves, you see something like this, little bit of curved appearance. You see the piriformis muscle here, and as you reach the ischial spine straight, okay, and subsequently medially continue the sacrospinous ligament. And as you go down these lesser sciatic nerves, you see the obturator internal just wrapping around. You can see like that. Okay. So a few pearls for the sciatic pudendal block. Actually, scanning steps again. Look for the ischial spine straightening up and how the sacrospinous ligament attaches subsequently, and identify the blood vessel. A bit of heel toe maneuver, kind of looking into the pelvis helps, and look for the sciatic nerve. See here, this is the pudendal nerve somewhere here, and sciatic nerve is not very far away. If you put a needle further laterally or kind of do a rapid injection, high volume, the local anesthetic will just spread and kind of block the sciatic. This is going to temporary block, but you must warn the patient. You must let the patient, because by the time you think of discharging the patient will have a bit of foot drop, weakness, you will not be able to stand properly. So make sure that you do a slow injection and identify the spread into the sciatic nerve. Okay. Next two parts, another thing in the pelvic area is commonly that we see a lot of patients with a radiculopathy, and that from the gluteal pain and goes into the leg also. One of the interventions that we do, caudal epidural injection for anesthesia purpose, for radiculopathy, also lower radiculopathy, and even if epidural adhesiolysis in the post-laminectomy pain syndrome. This is how it looks like, like frog eye appearance. This is two sacral cornu there. This is sacrococcygeus ligament on the top, this floor of the spine, and this is the sacral hiatus. Okay, and when you scan, like first you scan is most of the time it is a linear high frequency probe, and you scan in the short axis view, and this is how it looks like. Okay, two cornu, sacrospinous ligament. This is this floor of the sacrum. Okay, that is again hyperechoic line, and in between that black area, that is the sacral hiatus. Okay, and subsequently this is how it is, sacral hiatus. And subsequently, the next step, you change to a long axis scan. In the long axis, you should be looking like this. The flood is again the spinous process of the sacrum, and this is the sacrococcygeal ligament. Okay, from here it goes attaches to the coccyx, and this is the sacral hiatus. Your needle comes from caudal to cephalad like this. Okay, so that helps in putting the catheter. You can do adhesiolysis, hydrodissection. Okay. Okay, so this is again just to show you, this is the sacral hiatus floor, and this is the top, this fragmented line, that is the sacrococcygeal ligament. Your needle should pierce that. Okay, have a look at small video over here. Okay, this is just again another repetition over here. Okay, small video. So this is my sacrococcygeal ligament there. Okay, that is my needle, sacral hiatus, the needle coming over there. There, okay, it's just about to pierce the sacrococcygeal ligament, and now entering, about to enter. Okay, here you go. It is now entering the sacral hiatus. Such a flat line, I can put my catheter all the way up to L4-5 even also. Okay, and then subsequently, so once this is done, I just just show you, this is a bit of saline, the sacrococcygeal ligament, the sacral hiatus. Okay, so that means you are in the right place. Okay, and then once this is done, I check with fluoro. An injection, then it's perfect. I just reduce so much of fluoro exposure. Sometimes you do not get the CM with a busy or over setting also. So you just need 2 or 3 shots to rule out any intravascular uptake, and then subsequently put the catheter and do the injection. In the earlier studies that was done in 2005, this is very high success rate. You can put the needle in 100% of the cases. This kind of simple block. Those of you who are not doing it, you should go back and start doing this procedure. Very rewarding and very easy. Finally, I'll just cover the SI joint. It is a big diarthrodial joint. Okay, I'm 20 minutes. I have done sacroiliac joint. So here, what happens in the sacroiliac pain is one of the very common pain conditions. A bimodal distribution happens in middle-aged persons like 30s, 40s, also in the old-age person. So it is not the joint. It is not the joint itself. Other joint capsule, ligaments are also equally source of the pain or the pain generators. Okay. So just to show you how to do ultrasound guided injections, we know that SI joint injection, we do dorsal part of the SIJ and inferior part of the SIJ injection we do. So at the upper part is kind of fibrocartilaginous, that is sometimes is not possible to enter the joint properly. So this is how it looks like. The iliac crest, ileum is at a higher level, ileum sacrum is at a lower level. That is how we look for the ultrasound sonoanatomy view also. When you are at the lower part where exactly you do the injection, the sacrum and ileum are at almost at the same level, and the small cleft, that is how it looks like in ultrasound. So again, most of the times when one can see one thing, let me go back. So usually the SI joint is just lateral. The lower part of the SI joint is just lateral to the S2 foramen. These are the sacral foramen, just lateral to the S2 foramen. So when doing the procedure, it is prudent that one identifies the sacral foramen. You can easily count them also, identify S2 foramen also, and just lateral to it. Okay, have a look. So foramens are the small openings. So this is medial, this is lateral. Okay, so this is median sacral crest. So this is a small opening here. The ultrasound beam is able to go. You can see something going down here. Otherwise, you see black. So there's a foramen. Just lateral to that, there is elevated. So these are all articular pillar, the facet joint equivalent to the lumbar spine. That is called transverse sacral tubercle or the lateral crest over here. So just lateral to that, that is the cleft for the SI joint. In the beginning, it is a little bit difficult, I know, to identify the SI joint, but with bit of practice, one can easily identify the SI joint and do the injection also, out of plane or even in plane also. Similarly, this is the SI joint. Okay, one can do in plane approach from medial to lateral. And then, okay, let me tell you one thing here. Studies have shown that not only the SI joint, the extra articular, all the ligament, interosseous, the sacroiliac, all those ligaments, they are also rich in nociceptors. In fact, in young patients like 30s, 40s, most of the times the ligaments are the culprit, and it has been found that extra articular injection is equally efficacious like that of intra-articular injection. So do not struggle a lot if you're not able to put a needle inside the joint. If you're just around the joint, just finish the injection. That is going to be equally beneficial as well. Okay, because I remember in the beginning years, some 8-9 years ago, some of the patients were kind of struggling, bone hitting, and then so no need to worry about that. Make sure that you're not into the foramen, you're not injecting into a nerve root, circle nerve root, or somewhere you don't see your needle tip, you have not gone into the pelvis, by any chance. So avoid those. So for injection, okay, here is a video. Okay, median sacral case, going lateral is the parasacral muscles over here. Okay, so this is again an upper level item, at higher level is the foramen. Okay, so this is the foramen, proiliac S2 foramen, and this is sacroiliac. This is a very thin patient, the sacroiliac joint going up. So in the upper level S1 foramen, now at the S2 level foramen. Okay, so going up again. So this is S1 foramen. Now it is S2 foramen. Okay, sacroiliac joint. One can come from. So this is actually able to do that in a. So this is at S2 level. Okay, so this individual is very thin, and one can do with a linear probe, but in other patients, most of the times it's better to do with a curvy linear probe, low frequency curvy linear probe. Okay, have a look at a small video here. This is again S2 foramen, needle. Okay, see the needle coming over here like this. Okay, going about to enter the joint. Okay, this is not as simple as it looks like. In the beginning, it can be challenging also. Okay, this is going to repetition under the video. See here how the needle goes. So this is the SI joint. Needle goes. can see, you just should not have to enter the, okay, it is the teeth, enter the joint, perfect, there you go. Okay, once you do that in the beginning, you can take a fluorosearch, see here, inside the joint. Okay, so that means SI joint is very much doable with ultrasound. So I think I have covered most of my planned lecture. So just 1 minute or so, you can do this is a very interesting paper 5-6 years ago came up, the innervation and how ultrasound can help in. So this is called posterior sacral network, the innervation. Subsequently, in that study, they found, used to do S1, 2, 3, sometimes L fibrosarcomas and L4. So they found that majority of the innervation to the SI joint is from the S1 to S3, only 8% from L5 and 4% from S4 nerve. So kind of this called as posterior sacral network. They all travel. So just lateral to, this is called lateral sacral crest, the transverse sacral tubercle. With ultrasound, we can identify this transverse sacral tubercle. We can identify this foramens. Just lateral to that is that elevated part, that is the transverse sacral. So this is the place where you put the needle for a diagnostic lateral branch block or even for a RF also. Okay, one can identify this is F. One can long axis scanning. One can identify the foramens, S1 to S2 foramen, and then subsequently go a little lateral. Okay, that is lateral sacral crest, where you can put a cryoprobe, a cryoablation also with ultrasound guided, and even can put a RF ablation canal also, Trident cannula, cooled RF probe, and do the injection. So my take home message: systematic scanning in the pelvis, where sometimes you feel lost, which is what muscle, which is the piriformis, gluteal, you don't identify. So that helps in identifying these structures. Take it one step together, and then visualize the blood vessels, especially the inferior gluteal vessel, internal pudendal, and separate them. And ultrasound actually helps a lot in these procedures. Okay, I have skipped few things, so I think I'm not going to talk about that. Thank you very much for the patient hearing. And if there are any questions, I can take it now. Hello, Krishna ma'am, are you there?
Yeah, thank you.
Thank
It was
you.
fantastic lecture, Rajinder. Just someone asked how much volume you inject in SI joint
Yes.
ultrasound guided.
Well, SI joint is always less, not more than 2 to 3 ml. If I'm able to get into the joint, I inject half of my medication inside the joint and half outside the joint. So I take 2 ml of local anesthetic, 1 ml of steroid. So that is a total of 3 ml, sometimes 3.5 ml, half inside the joint and half outside the joint around the ligaments.
And for caudal epidural?
Caudal epidural, okay. So caudal epidurals, I take 2 to 3 ml of lidocaine, 40 to 80 of dipomedrol, and some around 7 to 8 ml of sterile normal saline to make it a total volume of 10 ml or so. And so it is essentially just 2 to 4 ml of 2% lidocaine, 6 ml of normal saline, and 40 to 80 of dipomedrol.
For the pudendal nerve, you go medial to lateral or lateral to medial?
Medial to lateral all the time. Lateral to medial may land up in problem like, you may end up injecting into the sciatic nerve in atropotendal. It's always medial to lateral.
And how much volume you inject for pudendal?
I told around 2 to 4 ml. 2 to 4 ml, slow injection. Make sure that it is spreading around the nerve, not going laterally to block the sciatic nerve. 2 to 4 ml of local.
Lecture.
Thank you very much. Thank you.
Yeah, everyone is pressing. And thank you for coming early from your holiday.
Thank you. No problem.
We want to listen you. Yeah, thank you.
Thank you. It's always a pleasure. Thank you, ma'am.
Devanjali?
Yes, ma'am.
Now we can proceed to next.
We can proceed to our next session. We will go to, with the permission of House, we are going to Dr. Madan Mangala Pandian, who is FIPM CIPS after his MD and in charge of Pain Clinic in Pondicherry, IGGGH and PGI. So he will be discussing on the shoulder pains and the interventions of the shoulder joint. Sir, please start your discussion.
Yes, I'm sharing my screen. Good evening, everyone. Am I audible?
Yes, sir, you are audible.
Yeah. So I'll proceed actually. Means like it was very, very elaborate lecture by Dr. Sahu. One more thing which I wanted to add upon, actually recently I had a complication with one of my pudendal neuralgia patients actually. I was in deep discussion with Dr. Sahu. I did a pulsed RF and I had landed up with a patient with sciatic nerve block, accidental. and it took 24 hours for the patient to actually get rid of that block. Means really tense moments. We had to do all the imaging modalities, all that. So we need to know the complications and side effects of each and everything which we do. Okay, so we enter into shoulder interventions. Sometimes I feel like shoulder is an ever expanding thing, particularly with the ultrasound. Actually, means like with fluoroscopy, not much could have been done, but definitely ultrasound has shown the way, particularly with regard to shoulder ultrasound and interventions. I'm going to discuss this in Dr. Krishna has actually ordered me to stick on to time, 20 minutes, not more than that. Long head of biceps, tendon sheath injection, the bursa injection, the AC joint, glenohumeral joint, suprascapular nerve block, something on the PRP injections, Barber-Touch, and very new procedure, the SHAC procedure, the shoulder anterior pericapsular procedure, which is something which is very much upcoming, right? This is kind of biceps tendinitis. I just want to show here just only those basic procedures, and I must stick to only the procedures. So I have done only that. This is the greater and the lesser tuberosity of the head of the humerus. You can see the greater and the lesser tuberosity. You can see there is the biceps tendon inside, and you could see there is a fluid collection inside, and you could see the sheath around it. Okay, this is how you diagnose biceps tendinitis, along with a clinical correlation. A clinical correlation is a positive speed test and positive Ergason's test. Okay, these two things you actually have to do it and then correlate with your clinic, means sonological correlation. Now I have tried to do a sonology of a biceps tendon which is inflamed. I'm trying to show you both the things actually. Means this is the short axis view, and I'm trying to show you the long axis as well, right? This is the long axis of the tendon which is appearing, around which there is a fluid surrounding it. You could see a lot of angry vessels around it. This is indicative of a tenosynovitis of the biceps tendon. Generally, the biceps tendon is never communicating, the tendon sheath is never communicating with the bursa. Only if there is a tear, it will be a communicated tendon sheath. Otherwise, there is no communication, right? This is an in-plane needling, which I have shown here. For in-plane needling, what you need to actually do is slight external rotation of the shoulder. Unless you rotate the shoulder, you may not be able to do a good in-plane needling, because there will be a greater tuberosity which will be coming in your way. So always try to do the in-plane needling with the patient's shoulder slightly externally rotated, right? Next, these are the two things actually which I wanted to show here. This is an in-plane needling, and this is an in-plane needling, and this is an out-of-plane needling for the same patient which I have shown here, right? This is the out-of-plane needling. The needle is not visible. Basically, it has come down from here perpendicularly in between the groove, actually, that is the intertubercular groove where the biceps tendon sheath is present. This is an in-plane needling. This in-plane needling, actually, the needle has come from here on. Just a moment. Right. So what all can we inject actually? It can be just lignocaine as a diagnostic test. It could be a steroid, could be dextrose, platelet-rich plasma, and anything and everything which I have mentioned above can be injected. But I take care, I avoid the artery, the tendon, and the volume should be very, very precise, not exceeding 1 ml. Generally, don't inject too much of volume into the anything actually. For any intervention as a diagnostic block, do not inject too much of volume, because it spoils the party. It actually does not give you any diagnostic value. Give only 0.7 to 1 ml. That means that lignocaine will be around 0.5 ml. The steroid will be around 20 milligrams. So not more than that should be injected into the biceps tendon sheath. Next, moving on to the AC joint. AC joint is a complex joint. All of us do understand, means a lot of things to learn from the anatomy. But I use the AC joint for 3 purposes. One, to look at whether the AC joint is a cause of impingement, whether there is a AC joint arthropathy, or if there is a rotator cuff. There will be a rotator, if there is a rotator cuff complete tear, sometimes the patient will not be able to move the limb at all. So in such patients, you always have something called the Gieser sign for the osteophytes, spur, and the joint profile. The joint profile is very, very important because it will show you the shape of the acromion, it will show you the spurs, it will show you the osteophytes, everything. And obviously, without a dynamic examination, the shoulder examination is never complete, right? This is what is called the Gieser sign. See, this is a patient who actually came yesterday. We had discussed, means I had discussed with Dr. Sahu also. This is a patient who had a traumatic injury to the supraspinatus, and there is a cortical surface tear. And because of which the patient is unable to move the limb at all. This is the diagnostic thing which I had actually. This is the AC joint of this patient. There is a small osteophyte sitting over there, and this is called the Gieser sign. You could see the synovial fluid which is effusing into the joint. This is called the Gieser sign, which is very much indicative of a patient with complete or near complete rotator cuff tear. This is a patient who is 69 years old, diabetic, right? How do you do the needling? Lot of answers. You can do it out of plane, you can do it in plane, but when you do it in plane, actually the patient should be either sitting with the limb down, or the patient should be lying down trying to reach the knee of the patient. So comparison actually between blind procedure and an ultrasound procedure, the blind procedure has got only 1/3 of success rate than the guided procedure. So the target, where should be the target actually? The target I have clearly shown here. This is what is the target should be. The target should never ever cross into the joint. It should always cross the capsule of the joint and never touch either sides of the bone, because this can cause osteolysis because of the steroid. Later on, the patient could develop pain. The volume, not much, again, 0.7 ml, 0.5 to 0.7 ml, mix it up with 10 milligram of triamcinolone with another 10, means 0.5 ml of local anesthetic, that will suffice actually. Always when you do any intervention for shoulder, all these small bursa injections, AC joints, biceps tendon, do your clinical test before and after the procedure to immediately notice and signifies good success rates. Means like unless you do the clinical testing before and after the procedure, you cannot satisfy your patient, right? What are the injectates? Possibly lignocaine, steroid, dextrose, PRP, and all that. The only thing which I need to take care, I will always take care is, don't go too deep. One, steroids can actually spoil the putty. It can cause osteolysis. It may sometimes enter into the rotator cuff itself, because steroid injection into the supraspinatus in the window between the AC joint actually can cause more problems. Now, subacromial bursitis. So what are all the differential diagnoses? What are all the differential diagnoses for a subacromial bursitis? It could be rotator cuff tendinopathy, it could be an impingement, and it could be just a bursitis. So all these actually require clinical as well as sonological confirmation. So lot of us actually do come across with such a situation that there is an impingement, but how many times have we correctly done our impingement testing? Generally, when you do the impingement testing, always place your patient comfortably on a stool, not on a chair, on a stool. Expose the AC joint on your sonogram, expose the acromion fully, and expose the supraspinatus as well. See all the three structures, the AC joint, the acromion, and the supraspinatus. All these three put together. Try to do the lateral abduction. Okay. Now you try to see there is a bunching there. There is a bunching of the tendon, and there's a small calcification which is appearing there. That is what is called impingement. So what is impingement? You should know. You should do a clinical impingement test. You should do a sonological impingement test. Follow it up with local anesthetic injection into the bursa, which will actually reduce the pain, or sometimes the pain vanishes immediately because of the correct placement of your local anesthetic. So this is called impingement testing. So bursitis, what is bursitis? Careful examination of the rotator cuff should be done. See, the rotator cuff will appear normal. A patient who is actually having a Nair's test and a Nair-Hawkins test positive will always tend to have either a tendinopathy or a rotator cuff tear, or could be a cortical surface tear or a bursal surface tear, something or the other will be there. Always try to do a good clinical examination of the rotator cuff. Good sonological impingement test must be carried out. Always do a post lignocaine impingement test to confirm whether this is the real pathology. This is the only pathology existent, right? So this is how you do the bursa injection there, right? This is the exact sonogram picture which you get at deltoid. Then the supraspinatus, you could see the same bird's beak appearance, right? This is a live imaging. This is the acromion here. You could see the supraspinatus. You could see there is a needle coming from the right side of the screen and going up, right? I have just used dextrose here. I have just used lignocaine and dextrose here. And this needle, for information, is a 26 gauge, 1.5 inch needle. Generally, I give local anesthetic, proceed further to just, because this is not steroid which I inject. I have lost faith in steroid in clinical practice, particularly in shoulder, because there are other better drugs which provides same or sometimes even better pain relief. Sometimes a little slowly, but definitely it gives good pain relief without much of side effects, right? So what is means like before and after the impingement test you should do? It is actually done in bursitis, rotator cuff tendinopathies, and the injectates could be lignocaine, steroid, dextrose, or PRP. It can be done either blind or ultrasound guided. Play it safe with steroid. Never inject into the tendon which is already diseased. Generally, the volume which I prefer to give is around 4 to 6 ml. It is according to literature by ultrasound guided procedures by Dr. Samir, right? Glenohumeral joint, it's a true shoulder joint. Actually, it is a true shoulder joint. And actually, it is a very unstable, means large range of movements at the cost of stability. So what all it communicates with? It has an anterior recess in the form of a rotator interval. There is a posterior recess which all of us are familiar with, and there is something which we are never familiar with is an axillary recess, and we are never comfortable with because it's hardly 2 millimeters of size. And only thing is, the problem is the sterility is a major concern, particularly when you do needling. But axillary recess is one area where actually you can prognosticate and diagnose actual adhesive capsulitis. So what are the indications for a glenohumeral joint injection? A degenerative joint disease, adhesive capsulitis, rotator cuff disease, and a labral pathology. Sometimes you can even make out labral pathologies by ultrasound guidance. So what are the possible injectates? A lot of injectates are there. Again, lignocaine can be done, generally commonly done is lignocaine, dextrose, saline, steroid. And generally, if you use a steroid, it's only not much of volume. But my area of interest, all adhesive capsulitis, I use only normal saline, sterile normal saline. Initially give around 10 ml of 2% lignocaine, follow it up around 50 ml of normal saline. It is a little bit slightly on the higher side. Sometimes it may cause capsular distension and a small rupture, which is actually beneficial, which is not at all a problem if it is done sterile. Okay, this is how I do the normal sitting position examination for any patient with for any glenohumeral joint posterior recess examination. And this is a common procedure which I do it in my clinic. Glenohumeral joint hydrodissection with saline. This is only saline, friends. This is only saline. Don't get misled by the kind of particulate matters which are actually coming out. The kind of ultrasound probe position which is required for this, I have mentioned in the next slide. This is how I do my hydrodilatations. Generally, I prefer my patient seeing me. Actually, I see the patient's face, the expressions, the breathing, the color of the patient, everything is visible there. And try to maintain sterility. Just maintain sterility because you are into the joint. And these patients, particularly shoulder pain patients, are diabetics. Most of them are diabetics. So be very careful about this. So this is how I do it. Okay. Normally, once I detach the syringe, try to see the kind of pressure the saline is coming out. This is one very much indicator of how much the joint pressure is, the opening pressure. You could see there is a lot of saline coming out. This is nothing. This is local anesthetic plus saline mixture. There's no steroid into it. Patients are very, very comfortable. This is done after a suprascapular nerve block. I do a suprascapular nerve RF, followed up with hydrodistension with saline. So patient never has pain. Only thing is, I do an immediate mobilization on the day of procedure, 15 minutes after the procedure. Very nice results. This is another approach where you go for the glenohumeral joint. I don't have much experience about rotator interval injection, particularly because of my comfort with a posterior recess injection. Suprascapular nerve block, always all of you know that, means the indications. There is a painful shoulder, always try to do a suprascapular nerve block. Drugs, whatever drugs, lignocaine, you could do with steroid, all that. You could do a radio frequency neuromodulation at 42 degrees Celsius, particularly after a sensory and a motor stimulation, because you are actually handling a mixed nerve. It's a motor and sensory nerve. So always try to do the neuromodulation after a sensory, and it is only a pulsed RF which you must do, not a conventional RF, right? These are two things actually. This is for RF. This is an in-plane needling, trapezius supraspinatus. You could see the needle coming in here just into the suprascapular notch, right? After sensory and motor stimulation, you do the pulsed RF. And after doing this pulsed RF, I try to repeat the motor stimulation again. If the patient has a right kind of movement, the preservation of supraspinatus movements are documented. And then I go for local anesthetic blocks, particularly a 5 ml local anesthetic block will help you in immediate mobilization. Immediate mobilization is the one which important thing which you must do. Unless otherwise you do an immediate mobilization, the next day is going to be the same nightmare for the patient. This is a local anesthetic injection. The suprascapular artery can be seen. It is pulsatile. So underneath the ligament, the suprascapular, the transverse scapular ligament, underneath the ligament, I have just injected 5 ml of local anesthetic. The evidence level is very much significant actually. Means like there is an effectiveness of combination of ultrasound guided pulsed RF with a corticosteroid injection is exceedingly well. Means around 100 patients they have done. And this is another set of patients, around 74 patients recently done by Dr. Tolga. And this is again a very significant one. Out of 74 patients, more than 70 patients have got a 6-month good pain relief. Interventions on the tendon. Generally, we don't prefer doing it on the tendon unless it is something like a PRP. No steroids, means like steroids are contraindicated. PRP injections for partial tears, intrasubstance tears, and sometimes even a tendinopathy. I generally prefer not for tendinopathies, only for tears. No role for PRP in a complete or a full thickness tears, only surgery, particularly after doing an MRI. PRP injections can be done in, means like into the bursa also, it can be done into the joint, and all these sports injuries, the tendon tears, it can be done. This is a very nice image. Actually, this is a cricketer, actually a 20-year-old university player who actually has a shoulder pain because of repeated bowling. Actually, he had a cortical surface tear. You can see the cortical irregularity there. And what I have managed is I have done a bursal injection, a local anesthetic plus dextrose injection into the bursa. That is why the bursa looks distended, right? This is the acromion. I have done an in-plane needling to deposit the PRP here. Just watch out. This is the cortical surface. Cortical surface is irregular. There is a tear exactly right into the tear. The volume is not much. I have done only 2 ml of it. That means like it looks big, but I've done only 1 ml plus 1 ml of injected into the tendon wherever there is a tear. This is what exactly I want to tell all of us, all of you people, be it radiologist, be it a musculoskeletal sonologist, be it any pain physician, unless you realize the diagnostic importance, not means like you can't just do interventions just by going by an MRI. You have to do the interventions based on your finding on the scans actually, right? This is another patient who is again a short putter actually. He has got a multiple small intersubstance tear on the supraspinatus. You could see there is a thickened coracoacromial ligament. There is a small bursa as well. What I have done a PRP injection, and this is what I have done. I have aspirated whatever fluid which could come out from the bursa. I have just put into the bursa as well as the tendon, 2 ml each. And this is what the kind of results which I had actually. Just see, there is nothing, no fluid underneath. Okay. It has actually sealed very nicely. It has actually maintained the what to say, the tendon looks very much fibrillar, normal structured tendon after 6 weeks. So this is what you will exactly get. I have actually put up all these comparisons because there are still a lot of doubters regarding the efficacy and efficiency of PRPs. PRPs, choose your patient correctly, choose your PRP correctly, choose what you want to inject, how to inject, where to inject, and definitely your patient selection is very much important. If you select only those patients who actually deserve PRP, you are going to get good results. This is another patient actually, which I'll show you. There is a small, you can see the linear tear actually. This is a linear tear. There is another sports person who plays Kalari actually. There is a, means like that's a sport actually, it means a local sport. And that is a linear tear over there. You could see that's quite a big tear there. You could see the same patient after 12 weeks. This is how it has happened. The normal linear fibrillar structure of the tendon is well maintained. So the patient will likely to have a minimal pain because of these reactions within the means, like because of the blood products which you have injected in, but that will settle with exercises, right? Calcific tendonitis, all of us do know that we know how to do a barbotage and things, but when to do barbotage, when you have a good chunk of calcium there, when you have a good chunk of calcium there, this is after barbotage, I have tried to take out whatever calcium which has come out. Not many times you are so lucky to have a big calcium chunk. Sometimes you have a big calcium chunk. Lot of times you have very small specks of calcium which are actually there, and those specks are never to be touched because more damage to the tendon will be there. So for such patients, I prescribe only give a pulsed RF, follow it up with good exercises for the next 3 months or so. I think those small bits of calcium are going to disappear. Always try to follow your procedures, follow your patients, all these procedures which you do under ultrasound guidance. Prognosticate what you're going to do. Means ultrasound is a tool, diagnosis, procedure, and prognostication, right? This is a procedure, very interesting procedure, which recently actually has been done by Dr. Felice Galuccio, one of Dr. Sahu's friends as well. It actually shows us, it doesn't spare the articular branches of the axillary nerve, musculocutaneous nerve, and the lateral pectoral nerve. Sometimes after doing a suprascapular nerve block, we do an axillary nerve block also. But when it comes to axillary nerve block, whatever we see posteriorly are only those nerve, actually means the articular branches have actually emanated well before whatever we are seeing here actually. So for blocking the articular nerves, there is something which needs to be done, is the shoulder anterior capsular, pericapsular block rather. It should be done. Exactly, this is what the YouTube video, actually I've taken a snapshot from Dr. Felice's video. This is the one actually. You try to do basically you try to do a bend, like what you examine for the subscapularis. Try to see the subscapularis. Try to do a flexion and abduction. Try to do a flexion and abduction. You are going to see this particular thing. You are going to see there is a small fascia which is appearing here. That into the fascia, the needle should be here into the fascia, as well as in the pericapsular space right here, wherever my laser pointer is there. That's the pericapsular space. Exactly. See, the needle comes here, then it traverses further down, and there's another 3-4 ml of local anesthetic here. This is a substitute which he suggests are going to be better than your regular axillary block, particularly good for mobilizations of frozen shoulder. I've started doing the last 3 months, fantastic results, but without good number of evidence, I really don't want to actually commit here. There is something means on YouTube also, please go through that SHAC procedure, SHAC, right? I always underline this. The diagnostic value of ultrasound should always be taken into account rather than just doing interventions. Interventions, obviously, ultrasound can guide you. Always try to follow up after interventions, particularly those for regenerative medicine, which is actually the need of the hour. Then prognosticate how well these patients are going to behave. Try to learn a lot of diagnostic ultrasound rather than just guiding only interventions. Follow me on Facebook, Twitter, LinkedIn, and YouTube. Thank you so much for the opportunity, madam.
Thank you, Dr. Madan. It was fantastic lecture, actually. And there are many questions for you.
Questions, yes, madam.
Yeah.
Should I
Yeah.
start one by one, ma'am? The
Yeah,
questions?
yeah,
Yes,
yeah.
yes.
Please.
Okay, the first one is for what is the patient position for Barsal injection, sir?
Bursal injections. Actually, a lot of people actually do a bursal injection with the patient sitting. Generally,
Yeah.
like I mean, it's like with whatever I do, I have last year my count on shoulder interventions were 480. So I think like I can say something like on whatever I mean the trial and errors which I have done over. I have done with patients sitting. I have done with patients lateral. I have done with patients supine. Generally,
Okay.
do only with supine. Do only with supine. Always with the patient supine. If you place the probe with 45 degrees pointing to the tragus of the patient, you can see the means like you can see the bursa. Sometimes, if you want to see the acromion also, you can place your probe right like this. You can place your probe right like this.
Okay.
Still you'll be able to see a good image of the acromion. If you can see the acromion, you can see the bursa, and you can see the supraspinatus also. For your information, again, this is an image which was done like this. You can see the acromion, you can see the supraspinatus, everything is possible here. Okay, so
Okay.
I always advise people to follow lying down, supine.
Supine position. Okay. So,
Supine.
so what is the next question is, sir, what is the concentration or volume of dextrose? I think in
Dextrose
case
I
of
use
Barsal injection, but
all
in
the
which
all the
injection you have mentioned? Okay.
all the Bursal injections I use 5% dextrose, madam. 5%
5%
dextrose, 2
dextrose
ml
and the
of
volume is 2 ml. Okay.
yeah, 2 ml of local anesthetic followed by 4 ml of dextrose.
Okay, sir. Thank you.
Can just
Next is,
interfere, Devansh? Just Dr. Madan, what is your experience? PRP versus 5% dextrose for Bursa?
For Bursa, dextrose is much better, madam.
Much better.
dextrose.
But
Cost
if you are
effective.
okay,
Mhm.
but it is for only Bursa. But if it is some tear and you want to do PRP, then will you do the PRP for Bursa also, or will you divide?
Actually, if I have to do for a tear, I will prefer giving dextrose into the Bursa, and then
Okay.
for tear, I want to give a PRP.
For
Okay.
AC
So
joint,
unless for AC joint, only steroid, madam. Only steroid. I have never used PRP because it is not cost effective for AC joint, madam.
okay. And for PRP, how many sittings you do? Do you repeat?
Normally I do two sittings.
How much interval?
6 weeks. 6 weeks intervals, madam. That is what I say. You just do a scan. You know there is a tear. Try to put it into the tear. Try to see the patient after 6 weeks. Not just jump into a conclusion whether this patient requires a PRP after 6 weeks. No. Try to see by clinical exam. Try to see the patient symptoms and try to see it by sonology. Unless you see all this, corroborate everything, the need for PRP should be compelling. Unless otherwise there is a compelling reason to go for a PRP injection further, I wouldn't even go for sometimes a second sitting is unnecessary.
For adhesive capsulitis, you always do the pulse RF of the suprascapular, or sometime only the diagnostic block and do the.
No,
Because
madam.
all
Actually,
patient, maybe all patient can't afford or can't be ready for the pulse RF. Then
madam, for any adhesive capsulitis, the funda will be actually to immediately mobilize as early as possible. The patient comes with a stiff shoulder. More than that, there is pain. So, which is more actually, you can't gauge now. Now, the thing is, you put in a bursa injection. You put in a bursa injection, you do the impingement test again. So, after doing the impingement test, you have some kind of a pain relief. Then follow it up with a local anesthetic block into the suprascapular nerve, maybe with added steroid, actually, if at all. I don't use steroid, but definitely we can use steroid for a suprascapular nerve block.
I normally add dexamethasone.
That's what. When we do this, definitely the patient is likely to have a good pain relief. Good pain relief, at least for the mobilization immediately. The moment you get this, I do a hydrodilation of the shoulder with saline. Immediately within 15 minutes, you can do the mobilization.
Yes, normally I do. That's
And,
why I
and,
asked
and
you.
normally I really means like I really don't involve the physiotherapist for immediate mobilization, because patient comes to you for both for the pain, the symptom, as well as the functional restriction. You are supposed to address the functional restriction at least partly immediately, and then go for means home exercises. I prefer going for home exercises. The Amazon pulley is really working wonders actually. Means like because of COVID, not many patients are keen on going to physiotherapists. So definitely the pulleys at home, they are doing much better job than the physiotherapist.
Okay, thank you, sir. So my next another question is: do you give suprascapular block in tendon pathologies intervention? From Dr. Subinay Saxena.
I didn't get your question, madam. Please repeat.
Okay, do you give
suprascapular
suprascapular block in tendon pathologies intervention? I think in tendinitis or like that he is asking.
Madam,
Or
if it is
tear.
only a
tear.
tendinitis, if it is only a tendinitis, impingement test before and after local anesthetic, maybe with dextrose or steroid will do. Only what you require is only a bursa injection. If it is only tendinitis, if it is a restriction of movement, if it is a shoulder pain even after doing the local anesthetic into the bursa, then you go for suprascapular. Basically, you just have to plan your procedures on a day. I use around 3 gloves for a patient with shoulder pain. Try to do the bursa, then do the impingement. If the impingement is still painful, again go for the suprascapular. Still there is restriction, then go for the hydrodilatation. Basically, there is a stepwise approach which everyone must follow, rather than actually having a shoulder patient do everything on one patient. Generally not required.
Okay. Thank you, sir. Thank you for the nice lecture. Ma'am, can we go to the next session?
Yes, please.
Okay.
Thank you, Dr. Madan. It was fantastic.
Thank you.
And our next session, madam, should I invite you or Dr. Navita?
Dr.
I think
Navita.
Dr. Navita. Okay.
Yes.
So, Dr. Navita, hello, can you hear me?
Yeah, I can hear you. Eventually, I can
Okay.
hear you.
Dr. Navita is from consultant pain medicine and palliative care in Kokilaben Dhirubhai Ambani Hospital and Medical Research, Mumbai. She is the first woman in India who is certified interventional pain sonologist from New York, USA. Ma'am has several experience in neck pain, back pain, cancer pain, chronic pelvic pain. Ma'am, please start your discussion.
Thank you, Deepanjali, and thank you, Dr. Krishna, for inviting me for this lecture. I would be talking about ultrasound guided interventions around the hip. What I would be talking about would be 4 things: hip joint intra-articular injections, trochanteric bursa injection, and 2 nerves, that is the obturator nerve block and lateral femoral cutaneous nerve block. So we all know till now that for the sonoanatomy, we need to know the anatomy. Just to brush up the hip joint anatomy, we know that it's a ball and socket joint between the femoral head and the acetabulum. There are many ligaments around it. One of them is the iliofemoral ligament, which is one of the strongest in the body. Posteriorly is the ischiofemoral ligament, then the pubofemoral ligament. Why the importance of iliofemoral ligament is that it attaches from the head till the neck. So and the extension of the iliofemoral neck ligament is the iliofemoral recess, which extends to the neck of the femur. And this recess, it connects with the hip joint, and that is where we have to give our injections. So that is why it is very important that how do we do it and what is the window. So this is the window we have to look for. How do we start? Directly starting the procedure, how do we do it? We have to use the curvilinear probe because it's a deep seated joint, so we have to use the curvilinear low frequency probe. The patient position is in supine position, and the hip can be a little bit externally rotated or neutral position, whatever position you like. The how do you start? It's the in the because we have to know that there is a little bit obliquity in 10 to 5 degrees of oblique. It's rotated externally in the hip, and the neck and the head of the this thing acetabulum and the head of the femur, there's around some degree of obliquity. So we have to keep it parallel to the head and neck, because this is the area, that's the iliofemoral recess we have to find, and this is where we have to put our transducer along or parallel to the femoral neck, and this is what we get. So that's the femoral head and that's the neck. So junction of the head and neck is what we are looking for, and this hyperechoic part is the iliofemoral recess till here. So anywhere from here till here we can give our injectate, and higher up would be the acetabulum. Now the pearl over this is that because we are crossing a superficial, this is the artery which we have to look for. Once we find the window, we have to put the color on and find out the vessel around it, because we'll be going here. So the superficial circumflex femoral artery, it winds around the neck of the femur. So we have to put our color on and look for it, and we have to go above or below the vessel. So this is once when we have identified this window and we find out the best window for our injection, we put the color on and look for the pulsations and the color, and we find the circumflex femoral vessels, and the needle trajectory is either above it or below it. So we have to, it's a deeper part, so we can see it's around 4 centimeters from the surface, and it will be a little bit, the trajectory would be from caudal to cephalad, and so it would be, we'll be needing a long spinal needle, and because it's a ultrasound, the deeper we go, the less reflective is the metal. So if we take a larger gauge needle, that is a 22 gauge, which is what I prefer in ultrasound, so we can see the echoes in a better way. So that is what the image of the intraarticular injection. What are the indications of the hip joint intraarticular injection? Is the hip joint arthritis, which can be due to inflammatory or degenerative. Even in the avascular necrosis of the femoral head, we can also go ahead and do PRP, that's a regenerative medicine, because we can't wait for the patient will come for pain, and we can't wait for that grade 4 osteoarthritis, secondary osteoarthritis happening due to AVN, because the patient has to get relieved. It has also been seen, the literature says that if AVN is diagnosed early in the grade 1 or early grade 2, then in grade 1 can be reversed back to normal if we use PRP in the earlier stages. What are the injectates used for the intraarticular injection? We can use steroid, we can use PRP, prolotherapy can be done, and viscosupplementation can be done for arthritis. So this is how do we do it? There's a small video which I would be presenting. I will just stop sharing and then again share the video here. Okay, so as I already spoke that patient is in supine position, a little bit in a neutral, hip is in neutral or the external rotation, and the curvilinear probe is what we use, which is a lower frequency probe. Start laterally, it can be done from lateral to medial and medial to lateral. So the first approach is starting from below, from the thigh, and we see for the femur which was rounded, and we go up till it becomes flattened. So we have reached the greater trochanter. At this area we move laterally and put the transducer in an oblique fashion, coronal oblique, and find out this window which we had already seen. So that's the head, that's the acetabulum, that's the iliofemoral recess, and that's the neck of the femur. So the junction of head and neck and this hyperechoic area is the iliofemoral recess. We put the color on and look for the circumflex femoral artery, the vessels, and we look again, see for the trajectory. We put now this is the second point where we are going from medial to lateral. So this is the femoral vessel, and we can see we are just moving our probe laterally towards and look for this femoral head. Once when we find the femoral head, we put again change the direction of the probe in the coronal or in the oblique manner, which is parallel to that's the femoral head and neck. So these two, we can do any of the procedure which we want, lateral and or from medial from the femoral vessels, and find this window and the iliofemoral recess. And then after giving this is the local which I am giving, and after giving a local anesthetic, we use a spinal needle and we inject the injected. We know that this is the pulsating superficial circumflex femoral artery over here. I will just, not because of the paucity of the time, I've put the needle or the spinal needle, and we are looking for, that's the needle which is coming in plane approach, caudal to cephalad. And yeah, so that is the needle. This is again the same position, and that's the needle which is in plane, and we can see this disturbance, and we are injecting this. Here I'm doing a visco supplementation because this was a cancer patient. He was in active disease and he had secondary hip osteoarthritis, so I didn't want to use any PRP for this patient, so I did viscous Synvisc 1, which I used for this patient. So that is how we can go ahead and do the intra-articular hip joint injections. And let's go back to the second um, um, intervention which can be done, is the trochanteric bursa. So okay, so what is the evidence? Because this is an evidence-based medicine, and this was in 2015. It was published that ultrasound guided hip joint injections, they are more accurate than landmark. I believe that nowadays no one is going blind for hip joint injections. So this was a systematic review published in 2015, and they found out that 100% accuracy was found with ultrasound guidance. So, and it's office procedure, why not go ahead and do it with ultrasound? We know where we are going. We are not going into the vessel, we are going into the hip joint. Second thing is the greater patient, they come with a lateral thigh pain or hip pain on the lateral side, and they can't lie on the side of the affected area, or the left or the right. And the pain can be from the lateral side going radiating towards the knee. So this can be a trochanteric. This is called as greater trochanteric pain syndrome. This is an umbrella term which can include the trochanteric bursitis, which is again very rare, and mostly it is because of the tendinopathies or the tear of the glutes medius minimus or maximus. And there can be a trochanteric bursa, which is very rare, or there can be ITB syndrome, that is the iliotibial band syndrome. It can be because of this can give rise to this type of pain. Important here is that we need to know that greater trochanter has different facets. So if we go back to the anatomy, anterior facet, there's a lateral facet, there's a posterior facet, and the superior facet. So the glutes are inserted, the gluteus minimus is inserted on the anterior facet, gluteus medius is inserted on the lateral facet, and gluteus maximus is inserted on the posterior surface. So we have to come from above to below when we are scanning, so that we can diagnose if there is a tendinopathy of any of the gluteal muscles, or there is an actual bursitis or a fluid filled bursa below. It can be below. It's not, when we talk about trochanter bursa, it's not only the one bursa, it's a huge, it can be below the gluteus maximus. When it is present below the gluteus maximus, it is called as subgluteal maximus bursitis. When it is present below the minimus, it is subgluteal minimus bursitis. Or when it is present, when it is filled below the medius because of the overuse or the traction injuries, it is subgluteus medius bursitis. So that's again a picture depicting that there's the gluteus medius tendon inserting on the lateral aspect, maximus on the posterior aspect, and the minimus on the anterior aspect of the um, uh, uh, greater trochanter. Uh, when we, again, the probe used is the linear high frequency probe, because it's superficial. We can see it's around 2 centimeters depth. We can see the greater trochanter, and it's a transverse view. So that's the facet. It's just like a hut-like appearance. And here would be the lateral, that would be the anterior, and that would be the, again, the lateral, and down below would be the posterior. So Anteriorly would be the gluteus minimus, and the lateral side would be the gluteus medius, and if you go more posteriorly, it would be the gluteus maximus tendons. All around here would be the TFL, that is the tensor fascia lata. More into it when we go deep, if there is a bursal or if there is a fullness below the fascia lata, then because all above it is the gluteus maximus, so this whole bursa, if it is filled, then we see that it's called as a subgluteus maximus bursa. If it is below gluteus medius on the lateral surface, it's the subgluteus medius bursa, and similarly subgluteus minimus bursa. So we have to actually find out what is the pain generator, whether there is a, if this is a bursa here, here, or here. So we can, in a longitudinal view, this is a longitudinal view suggests in which it's a fanning out of all the tendons together. If it is just above the bone, it is the minimus, below the medius, and below the maximus. So this we have to always keep in mind, that which is the pain generator. If we really do not know, then we have to inject in all the bursae. It's always better to take care of all the bursae together rather than just putting it just below the gluteus maximus. So, or we can do a dynamic scanning, and then we can know which is the pain generator. So again, that's what it's the gluteus maximus below the maximus when it is just below the gluteus medius, and anteriorly when it is below the gluteus minimus. So we have to, this is a greater trochanteric bursa syndrome, and we have to we can actually see if there is a tendinopathy or a tear in the glutes tendons. What are the indication of injections? If there's a very rarely, if there's a bursal inflammation, bursal pathology, then we can do an intra-bursal steroid injection. Or if we see that there's a tendinopathy or a tear in the glutes, then we can go for an inject PRP, where we find the tendinopathy or the tears. What is the patient position? The part which is affected, which is the right or the left, it's a lateral decubitus. The left side, if it is left affected, left side up. If the patient is very bulky or obese, then we can go for a curvilinear, otherwise a linear probe is used, and we can use a spinal gauge 22 gauge needle. So this is where we have to go, and we can do both the transfers, as well as this is a sagittal longitudinal, as well as the transfers examination, and then inject in both the views. So this is the how we inject: lateral decubitus, the affected side up, and this is the linear probe because it's superficial and the patient is not so bulky, and we are using the spinal needle, and it's in plane approach. Here it's just when is just below the gluteus maximus, so just uh, uh, your tip of the needle should be just above the gluteus medius if you are on the posterior side or the lateral portion, so above it. And if you are suspecting the pain generator below the gluteus medius, then you have to cross this medius and then inject above the bone, touch the bone and above the bone. If it is minimus, then you have to come from the other side, or you can inject in the same needle, can go and inject over here. So that is what is more important. This I have already spoken about. This is one of the pictures with aspiration, which we can aspirate and then inject in the bursa. There's a huge bursal collection. Important thing over here is that there's no major vessel or nerve, so you are not going to hurt. There's nothing important vascular structure, no nerve over here, so we it's very safe. And it we should not inject. If you are injecting steroid, please, this is a rule of thumb, never inject into the tendons, because if we inject into the tendon, if there is a tendinopathy or if there's tear, we are going to cause more tear in the tendon. So it has to be just above it or below it. So we have to be very careful, and that is why ultrasound is very helpful in knowing, in precising that where is our tip of the needle. If you don't know the tip of the needle, it has already been discussed that put a saline and do an hydrodissection and see where is the spread. And if there's a bursal spread, it will go up and down. It will never stay and form a blab. If it is a tendon, then it will always be collection over here. If it is a bursa, it will go up and down. So you are very sure that whether you are in the bursa or you are not, you are inside the tendon. and you are causing more pain rather than causing, it's an iatrogenic injury to the patient if the steroid is injected into the tendon. Um, so this is how you can inject. It's an in-plane approach. It can be lateral to medial, so it's just above it, so it's a sub-medius bursa injection. Then coming to the nerves, so obturator nerve, I will be talking about hydrodissection of obturator nerve and the lateral femoral cutaneous nerve. Obturator nerve, again, we know that it is formed from the lumbar plexus from L234, anterior divisions of L234, and then they uh, uh, travel along posteriorly to the common iliac veins and descend through the fibers of the psoas and divide after coming from the obturator canal over here immediately into the anterior division and the posterior division. Anterior division supplies the adductor. It is in between the adductor longus and the adductor brevis, and it gives articular branches to the hip. And then the posterior division, it is you can find it in between the adductor magnus and the adductor brevis. So once when we know this, how do we what are the indications of the obturator nerve? For chronic pain, it's usually whenever there is a hip pain in AVN, mostly avascular necrosis, you can do a PRP along with the obturator nerve block, along with the fascia iliaca block, so that the pain, because the pain can be in anteriorly in the hip. There can be an adductor muscle spasm in which obturator nerve block can take care of the adductor muscle spasm. But those in AVN, they do have SI joint pain as well uh, uh, because of the ground reaction forces causing SI joint dysfunction. So they're most commonly the SI joint is also painful in that. So we have to look for the pain generator. And also, if you have a patient who have secondaries in the muscle, then again you can do a phenol neurolysis of this nerve in the cancer pain patients. And also, if patients they have spasticity, if you have patients who have spasticity of the adductors, then you can go ahead and do a phenol neurolysis of the adductor on this obturator nerve. How do we do it? Again, it's a very superficial nerve, so use a linear high frequency probe. The patient position is supine, but a little bit abducted, abducted, knee flexed, and externally rotated, so that the we can actually feel the tendon and start from the medial side, start from the femoral vessels, and then move laterally. So we are start from the femoral vessels and move medially. And so that these are the femoral vessels. When we move medially, this is the pectineus muscle, and then would be the three group of muscles, one over the other. The superficial most would be the adductor longus, then adductor brevis, and then would be the adductor magnus. So the plane between the adductor longus and adductor brevis would be the anterior branch of the obturator nerve, and the plane between the adductor brevis and the adductor magnus would be the posterior obturator nerve. So uh, this is the window for the obturator nerve ultrasound. This plane between the adductor longus and brevis and magnus. So once when we find this obturator artery, it accompanies this obturator nerve. So put a color on and find the vessels, put the color, and then you can find the obturator nerve. So this is the window which we had done in one of our patients. You can do an in-plane approach, you can do out-of-plane approach. This is the out-of-plane approach. This is the pectineus, this is the brevis, and that's the longest muscle. That's the out-of-plane. We can see the tip of the needle, and that's the plane here, and that's the spread of the injected. And again, let's go back to the video and see um, the other the let's come to this. Yes. And so this was the hip joint, and we start again. And yes, so that's the femoral vessels, and we are moving again. This is just explaining how the position of the patient should be. We are starting from the femoral vessels and moving medially. This is the pectineus muscle, and again more medially would be the adductor brevis. the adductor longus muscle, and more deep would be the adductor magnus. The anterior branch is somewhere here. We put the color on and find, we'll just, in a minute, we'll put the color, and we can see the pulsating artery over here. You can actually see it, and we can do, let me just, because of the pause, yeah, that's the color over here. We can see that's the medial to it would be the obturator nerve. That's the out of plane approach. And let's do it in plane approach. So this is the in-plane approach from lateral to medial. We know that we are far away from the femoral vessels. This is not there in the vessels are over here, and we are superficial. So that's the needle coming in and coming to to the fascial plane between the adductor brevis and adductor longus, and we are putting our injected in the area over here. So that's how we do the obturator nerve block. And um, then we'll again come back to the lastly is the, I'm so sorry, we have finished with this. Yeah. So lastly would be the lateral femoral cutaneous nerve. So lateral femoral cutaneous nerve, we all know it's arises from the dorsal division of L2, L3, and emerges over the lateral part of that's the psoas major muscle, runs over the iliacus, and at the level of inguinal ligament, it goes below the fascia iliaca and lies in the at the ASIS, and crosses the inguinal ligament below the fascia iliaca, and divides into 2 or 3 branches, which can be as it can be medial to the ASIS, and it can be the distance from the ASIS um, can range from 0.3 to 7 centimeters, which can be seen here. It's a very it's it varies from 0.3 to 7.3 centimeters, and it can be over the ASIS, it can be lateral to the ASIS. In 4 to 27, there's a huge range over here. 4 to 27% of the patients, it is lateral to the ASIS. Sometimes it divides before the inguinal ligament in 28% of the cases, and sometimes then it crosses the ASIS and courses laterally over the sartorius. Important thing why we are discussing is that we have to trace the nerve right from where it at the level of ASIS, and then trace it down where it divides into onto the 3 branches. So this is where in the cross section where it is medial to the ASI, the fascia iliaca, and coming laterally on the sartorius muscle, and more laterally is the TFL muscle. So it's very superficial, and again the probe used is the high frequency linear probe. We start, what are the indications? Most commonly is the meralgia paresthetica. Now because of the how the low waist jeans and the low waist trousers which all of us wear, is especially the young people, they come with pain in the lateral side of the thigh. And when we ask, there is no injury, no trauma, but only thing is that if we ask them, there is they do wear a low waist trousers or jeans, and which are very tight, and that causes the compression on the nerve. And then this, we can help them out by hydrodissection of this nerve. What can be used in hydrodissection is the local anesthetic plus steroid or PRP or 5% dextrose. So the patient position again is supine. The linear transducer is used and start from transverse in a transverse axis. So just start from ASIS and then go below in the inguinal ligament. We can actually trace this nerve from which is medial to the ASIS. We can see this nerve in between the both the fascia lata and fascia iliaca, and this is the nerve over here, and we trace it below the ASIS, and we see that there's a plane between the laterally is the TFL and the medially is the sartorius, and in between this plane below the fascia iliaca is the lateral femoral cutaneous nerve of thigh, and it is called as a cat's eye appearance because it looks like a cat's eye in between the 2 muscles. So special pearls over here, there is no vessel. it's very safe. But important thing is don't inject into the tendon, identify the facial plane, and also important is trace the nerve, and you can actually see where it is entrapped. So here we can see this nerve in this is a cat's eye, what I was talking about, the sartorius, and laterally is the TFL. So just cross, start from the ASIS, come down and look for this plane, and we can see the nerve and its divisions, 3 divisions also. How do we
नहीं
inject
खुली है
this?
सर
In
बाबा भी
hip
मैं जो तक
approach,
करती
so
आओ कि
that's the
नहीं
sartorius
अभी
muscle
देख
over
लो
here,
मैं कहीं
and I'm
काम
coming
है
from
कहीं
lateral to
काम
medial. There are two branches, two branches of the lateral femoral cutaneous nerve. So I'm hydrodissecting
मम्मी
both the
खाली
branches.
बेसन नहीं पूरी
Here, one, and the second, I'm coming down, and then I will
100 ग्राम
hydrodissect
मुगरे
this
ले
branch
लो
as well. So this is how
मैं टूचू
we do
टूचू
hydrodissection. It can be PRP, it can be 5% dextrose, or a local steroid, anesthetic and steroid. So in summary, I would say that ultrasound interventions in hip is it's very, very feasible. You can actually see what is it can be used as a diagnostic tool. You can see if there's a tear or a tendinopathy, what is the cause of the pain generator, as well as you can do the intervention in the same sitting. Thank you very much for, if any questions, I would be happy to answer.
Thank you, ma'am. Ma'am, it was an excellent presentation. So if anybody wants to ask any question, please, you are welcome. Hello, am I audible?
Yes, you are audible.
Yeah, Navita,
Okay.
I have one question.
Yes.
When it is a chronic hip pain or maybe AVN pain, do you do the pulse RF of obturator, or you do only the PRP plus diagnostic block?
We can
You do.
combine both, because it's always better, because the patient, the PRP pain, after injecting
Yes.
PRP, it will take a long time to settle.
Yes, yes,
So, but the
yes.
patient needs pain relief. So sometimes we have to combine the obturator nerve. You can do a RF first diagnostic, followed by an RF of the obturator with the ultrasound. I have done it, and it has got very good results. And also they also have always invariably, if it is grade 2, then they have SI joint pain as well. So we can do an SI joint intraarticular injection. We can do a PRP, intraarticular hip, and obturator RF, and they do very well, maybe for months together.
So do you do only obturator, or do you combine with the
I
articular
also
branch
do-
of the femoral? Because it
I
has
also do the femoral, the articular branch of the femoral, or the simple one is that you can do a fascia iliaca block along with the
Yes.
obturator. So that is
But
what I
some-
combine, and then along with, if SI joint needed, and PRP.
Sometimes some patients come with the fascia like pain, anterior pain. They come and with the sometimes there is a fasciitis
femoral,
type, or some of the
articular
hyperechoic.
branch of the femoral.
You can see. So what you do for those patients?
So again, hydrodissection, again, it is very important. They do, we have to, again, important thing is that we have to again see, sometimes the genitofemoral nerve neuralgia also presents like it is only in the anterior part. So
Okay.
we have to actually go up and see whether it's the genital or a femoral branch of the genitofemoral nerve which is involved or not. I have seen in a lot of patients that they come with the anterior thigh pain, and which,
Yes.
if you ask them, it goes to the mons pubis or the testicle, and because they never come up with that is also painful. They'll always say that it's the anterior thigh pain. So we have to look for the genitofemoral nerve as well, and we can do a fascia iliaca. Sometimes we hydrodissect, and then they do very well after this injection. And yes, because and mostly it is the obese patients which they come with this kind of pain. And I've also seen some young females in their late 30s, and when they go for nowadays for the egg freezing process, they come with this kind of, again, this kind
Yes.
of pain with
Because I get lot of patient with anterior thigh pain.
yes, anterior
So
thigh
they
pain.
come.
So,
Yeah. Dr. Harne has
And
asked.
two questions are there.
Yeah,
Yes.
Devanjali ask. Yeah. You can ask.
Can
it.
lateral femoral cutaneous nerve block be used for lateral thigh surgeries and the dose? Dr. Ravindra Harne has asked this question to Dr. Navita.
Sorry, when?
Can lateral femoral cutaneous nerve block be used for lateral thigh surgeries? The dose.
Lateral thigh surgeries as an anesthesia. Oh, I'm not
As
an,
a-
I don't,
Yeah.
I'm not an anesthesiologist by
I
background.
don't think it will
Yeah,
be
you
very much
can do.
suitable for
You
lateral
can-
thigh surgeries
yeah,
because
yeah.
it's very localized and very specific.
Yeah, but
Yes.
according to my understanding, alone this block will never help.
Never help. Yes.
Yeah.
Yes, yes. Another question is, when injection PRP in the lateral femoral nerve, must we inject where the nerve is entrapped?
Yes,
Actually, the
absolutely.
location of the injection he wants to know from you.
Absolutely. That is why we have to trace the nerve. Whenever we are doing any hydrodissection of the nerve, it is mandatory to do fully trace the nerve right from where we can see it. Whether we are going for ilioinguinal, iliohypogastric, whether we are going for genitofemoral, whether we are going in the leg, if we are going for lateral femoral cutaneous nerve of thigh. That is why tracing starting from the ASIS, locate it in the inguinal ligament, and then come down and then inject before it branches out. So always do the hydrodissection. You can actually see where the entrapment is and then do the hydrodissection where it is entrapped.
Okay. Dr. Navita, I have an experience as well as question to you. What I have found during obturator nerve block with the nerve locator, excellent jerking of the obturator muscle, obturator jerk, what we found, we used to see that and we used to give the injection. Is it suitable or USG guided nerve block? Which one is more specific and gives better result? I want to know.
Yeah, that's
Because
a
we
very
are
good
used
question.
to obturator jerk method. Huh?
Very good question, because I do a lot of phenol blocks, phenol neurolysis. So always combine ultrasound with nerve locator.
No.
That always gives a good result. Because with the ultrasound, we actually see the nerve, but with the nerve locator, we are very sure of how much near to the nerve we are. Because this is when we want to do a phenol block, or when we want to do the RF, we have to be as near to the nerve as possible. So it's always better that we use both together for the precision.
Combining these two methods will give more
Combining
good
both
result.
together. I always
Yeah.
combine both.
Thank you, madam. Thank you so much.
So,
Very
one
informative,
more
very
question,
nice
Devanjali.
discussion.
One more
One more
question,
question.
Devanjali.
Yeah, I can see it.
How many PRP for AVN?
Yeah, how many
Sorry?
PRP?
How many
How
PRPs?
many doses of PRP is required for early avascular necrosis of the hip
So
joint?
that is the literature for we don't have any guidelines, and especially for AVN, we don't have we don't have any guidelines for osteoarthritis also. But now the guidelines or the literature says that one injection is good enough. But for AVN, because it is a ongoing process, we have to repeat it. So the best thing is that the patient comes back to you once when you have done a good PRP, which is a leukocyte rich, because we want the inflammation to happen and the healing to happen. So a leukocyte rich PRP is always preferred in AVN. And once when you have done that, the pain is relieved. And if uh, uh, always, if the patient doesn't come back for 3 to 4 months, call back after 6 months and then do it. This is what I do. I have done in grade 3 osteo AVN also, and they have done well for 6 to 9 months. There's a lady who comes from USA to get her PRP done in AVN, because she's in grade 2 and grade 3, and still she's in the same grade what she was 2 to 3. It's around 3 years I've been injecting her, and she comes every 9 months, and she's doing very well. So I think so. The patient himself or herself is the you can say they themselves, they come back with the pain, or if they come back early, then we can do it early. But 6 months is the time when we should tell them, depending on the level of the AVN. If it is grade 2, they can do well for a year. If it is grade 3, advanced grade 3, you have to call them. You have to tell them that 4 to 6 months is what one injection will suffice. You have to come back and get done
In
with
one case, in our training period, we have seen that in early osteoarthritis of the hip joint, in late osteoarthritis of the hip joint, where the patient he had so many medical conditions and not suitable for THR, obturator and pudendal nerve block, once in a year, she used to come, we used to give, but she was satisfied with that.
the pain.
So response of the patient is also very important.
Is important. That's true.
Yes.
Absolutely.
Thank you, ma'am. Thank you so much. So
Thank you.
with the permission of House, can we move to the next session? Madam,
please.
Krishna madam.
Yes,
Okay,
yes.
so our next speaker is President herself. So I have already introduced Krishna Madam, Director of
Yeah.
Kolkata Pen Clinic. She will be discussing on the knee and foot
Yeah.
procedures and USG guided interventions.
Yeah. Thank you,
Please.
Devanjali.
Thank you.
Yeah, thank you all the faculty, and with my one call, in fact, Navita was on holiday, so Dr. Sahu was on holiday, and everyone came on this holiday season, and it is the weekend of the Christmas. And thank you so much with the fantastic, and I'm seeing still people are listening to us, and thank you for all delegates also to attend. So last topic I have kept for myself, that is a intervention for knee and foot. For the knee, because I will say whoever start the ultrasound, knee is very easy to do, because in knee what we do maximum all the genicular nerve and intra-articular injections. It's easy to do, so you can start with the knee. So I'll speak on the knee for the genicular nerve. I have taken saphenous nerve also. There are two reasons. Being anesthetist, we do lots of adductor canal block. And second thing, in the chronic pain, if I want to do the diagnostic block, or patient comes in with the severe pain of the knee, and I'm doing the PRP or PRP injection out sometimes viscous supplement, then if I do the saphenous, I combine with the saphenous, so that initial time, which takes time, 7 to 8 days patient takes, because whenever you inject PRP, the next day patient sometimes have the more pain because of the PRP injection, it take care. So what I do this adductor canal block with the local anesthetic and some dexamethasone, and then I give either PRP or Synvix. So this is the reason I have taken the saphenous also. So knee pain is a very common problem with the advanced age, and osteoarthritis is the most common cause. And we need this pain can come from the joint, periarticular tissue, and referred pain from back. As Dr. Madan said, he does lots of diagnostic in the shoulder, but sometime if the young patient is coming and I am suspecting there is a ACL tear or something, then I normally send patients to the sonologist, musculoskeletal sonologist, to do the diagnostic, and then I prefer to do the intervention. If patients are simply osteoarthritis, I am suspecting, then I don't send and I do directly. So this is the way how I do. And for the innervations of the knee is innervated by the articular branches of this is called the genicular nerves of the several major nerves, like it is coming from the branch of the femoral, tibial, and common peroneal, and saphenous and obturator nerve. Thus, mainly we do the three nerves: the superior medial genicular nerve, superior lateral genicular nerve, and inferior medial genicular nerve. And these three, these superior medial genicular and superior lateral genicular nerves are the branches of tibial nerve, which are branch of the femoral nerve. And the inferior medial branch, which is a branch of the saphenous nerve, inferior-medial, and the inferior-lateral branch, it is coming from the common peroneal nerve. So saphenous nerve block, as I said, it is one of my favorite, because I do at least many times, other than the anesthesia also. The saphenous nerve is the branch of the femoral nerve, and it is a purely sensory. Why I am talking about the saphenous? Actually, long back in 2009, when I went to US for training, I have seen that time for the osteoarthritis knee, they used to give the intra-articular steroid, of course, but with that they used to do the lots of saphenous nerve block, because it gives immediate relief. So from that time, I don't know whether I'm also following that. Most of the time in acute pain, when patients is coming, and when I'm not intending for the radio frequency lesioning of the genicular nerve, then I do the saphenous nerve block, because it is the only one nerve block which can help, and especially in the adductor canal. So saphenous nerve block can be done at the mid-femoral level or the adductor level. Patient's position for the saphenous nerve block when you are doing it at the mid-femoral level is the leg slightly externally rotated and supine. Patient is supine. After preparation of the skin and transducer, I use the linear probe with the 10 to 20 hertz. And normally you follow the femoral artery. It's very easy. You follow the femoral artery, and the sartorius muscle, and always find out the nerve is saphenous nerve is lies next to the femoral artery. And when we do the in the adductor canal, sorry. Yeah, want to do the adductor canal block, then adductor canal block is very easy. So here we have the sartorius muscle, where we have the vastus medialis and adductor magnuser, and it is a femoral artery. You always follow the femoral artery. Below the femoral artery, there is a femoral vein which is collapsible, and you can always give the color Doppler and you can identify the vein and artery, and the saphenous nerve is the just next to the femoral artery. So what happened? So you can see the probe position. So here again, you can see the sartorius muscle very nicely. It is thick muscles, and first you identify the femoral artery, and then you identify the sartorius muscle. Then you have the vastus medialis, adductor longus muscle, and there is a saphenous nerve. In the adductor canal, we have the nerve to vastus medialis also. It is a small nerve, and this is the most advantage part of the doing the block in the adductor canal, because that time we are blocking the saphenous nerve with the nerve to vastus medialis. So we use the normally 5 to 8 centimeter 22 gauge. You can use either the stimulation needle if you want to do, or they are the needles which is the echogenic, and you can use for the ultrasound guided, or you can use the 22 gauge spinal needle. I normally use the 22 gauge spinal needle, and we do the block from the medial aspect of the thigh, and we do the from lateral to medial. So you can see the position of a needle, and here is the nerve. So again the needle position, if you can see you can identify the needle. It is a sartorius, vastus medialis, and here is the nerve below the sartorius. For the genicular nerve block, we normally block the 3 genicular nerves: superior medial, superior lateral, and the inferior medial. As the inferior laterally, we don't do normally, because there is a common peroneal nerve which lies very close to the inferior lateral, and there is a risk of the injuring the common peroneal, or you can block the, because for the genicular nerve we do the radio frequency. In fact, I will say nowadays I normally do the cooled RF for the genicular nerves, because it gives the better lesion and bigger lesion and more specific lesion. So here is the suprolateral genicular nerve, the supromedial, and here is the inferior medial. For the supromedial genicular nerve, it is a when you keep the high frequency linear probe on the medial side of the femoral condyle, and normally I do the longitudinal scanning, because the advantage is when you can see the femur shaft is connecting to the condyle, and you can identify the curvature, and with that, if sometime you don't find the artery, many times you normally all the genicular nerves, they are associated with the genicular arteries, but sometime you can't, because there is very small artery and you can't find always the pulsation in some patients. Then you can do the longitudinal scanning, and you can take the convalescence of the condyle and femur shaft. If you want to do the injection in the transverse, then you can just keep the finger there and do the probe in the transverse scan, and then you can go from the lateral to medial. Or when you are doing in the longitudinal scanning, then you go cephalic to caudal. So here you can do in the sitting position when you want to do the just for diagnostic purpose, because or you can do the patients are in spine position with the knee slight flex. You can keep a pillow under the knee, whatever knee is doing, and you can do slightly flexion of the knee, because you are injecting with the intra-articular also, and both the things you can combine together. So what I was talking is that this is the convex, and then it is a shaft. Here is the condyle, so you can just do on the junction of the condyle and shaft from caudal. You can go from the caudal to cephalic. Superior lateral genicular nerve, again it is the probe is kept on the lateral side of the lateral condyle of the femur, and you can do the sagittal orientation, or so if you do the sagittal orientation, then you can do medial to lateral, and if you do the longitudinal, then you can go from the caudal to cephalic. Sometimes some people do the intermediates also, the genicular intermediates in the front, and then you can have the quadriceps and vastus tendon, and then here on the femur you can do. So it is from the cephalic to caudal. Inferior medial genicular nerve, it is again the probe is on the middle condyle, middle side of the condyle of the tibial condyle, and the transducer was then kept till the tibial insertion of the middle collateral ligament. If it is a longitudinal scanning, it is easy to identify, as I said, because in the longitudinal scanning you can find this the curvature and then the straight shaft, and then you can take the convolution. Sometimes you find the artery, sometime rarely you don't find. So here you can find out the artery and nerve, and you can go always cephalic to caudal. Again the scanning. The pulse is here, the artery is not always visible, as I said, on the superior genicular nerves, then target the bottom of the slope of the femur is sufficient. And in the plane can be tricky, and out of plane approach is same. Sometimes some people do, but I always prefer to do the in plane approach. You can do the out of plane. For the genicular nerve blocks, you can use the local anesthetic with the steroid or radio frequency. As I said, I normally do the cooled RF. You can do the cryo also. For the intra-articular injection, so for intra-articular injection, when we start the scan, we do the longitudinal scan and you kept above the knee and start the scanning, and you can find out the quadriceps, and then below that it is a patella, and here is the femur, and here is the suprapatellar bursa, and here is the fat. So you should always identify the suprapatellar pad of fat, and you can find out the small amount of the fluid in the suprapatellar bursa. This is normal, but if it is a large amount of fluid and patient is having the more pain, then you can aspirate also before injection, and after aspiration you can inject. So you palpate for injection, you palpate the iliotibial band, and you can see this is the hypoechoic suprapatellar bursa. It is the longitudinal scanning, and then you can do the transverse scan when you want to inject. So it is done the transverse scan, and here you can find out the hypoechogenic fluid. Needle is coming in the plane. You can identify very nicely. It's actually very nicely. You can see needle path again, and here as there is not much fluid, we are injecting. For again, needle will be guided into the suprapatellar bursa. So for the injection of the intra-articular knee, you can have the choice of the either local anesthetic. I don't, nowadays I stopped injecting the steroid because it can harm, but PRP is the best thing. I normally give the PRP, and when I inject in the knee, because it's a big joint, so normally I inject PRP mixed with the PPP and 4 ml, 3 to 4 ml of the PRP I inject, or you can give the either viscous supplement, which are the nowadays a one injection has come, so you can inject that. So sometimes this patient they have the lateral knee pain and they are coming with a iliotibial tight band, and sometimes there is a iliotibial bursitis. So we have to inject the iliotibial. This is the iliotibial band. When you are scanning the iliotibial band, you can come from the above to below, and you can find out. And when you can find out the hypoechogenic below this, then you can inject there. For the iliotibial band, normally we inject the PRP or maybe the local anesthetic injection to release. But more thing is coming. I remember one of the patient came with the lateral knee pain, which is similar to the L5 block or L5 canal stenosis. Patient came with the MRI and there is a L4-5 small disc bulge, but patient has the severe neurogenic pain in the lateral side of the pain. And even the patient went to the spine surgeon and they want to operate. And I was very confident of the common peroneal nerve entrapment, and patient had that. And when I injected and did the diagnostic block for the peroneal nerve block, and patient got the good relief. So this is a very, very common nerve which patients normally they have the common peroneal nerve entrapment. And the common peroneal nerve is actually very superficial to the lateral joint line of the fibula head. It may have the injury because of the direct trauma like the fibular fracture or knee dislocation, and sometimes direct the common peroneal nerve injury. Impingement can occur of the common peroneal nerve by the soft tissue mass like ganglion, exostosis, external compression due to the cast or braces, because sometimes patient had the fracture and they are on the cast or braces. And then one of the patient is coming to me, she has the she's the athletic, but she had the CVA. After that she has she wear the braces, and she normally complain of this lateral side of the pain. So prolonged squatting or even the habitual leg crossing may cause the common peroneal neuropathy. When common peroneal nerve you see, or common fibrillar nerve, so you can see this is here is the nerve. So here is the soleus muscle, lateral gastrocnemius, plantaris muscle, and you can see the popliteal artery, and here is the nerve. So normally when the nerve is normal, the cross-sectional area of the nerve is in the 11 millimeter square at the fibular head. But when patient comes with the common peroneal nerve pathology and it is swollen or maybe it is entrapped, then the cross-sectional area is the big, and it is a 22 millimeter at the head. So again, you can see most of the time you can see it's actually fibular head. It is so superficial, you can easily identify the common fibular nerve over the fibular head. And here the soleus, lateral gastrocnemius, and medial gastrocnemius, and plantaris. So you can easily identify the common peroneal nerve. So here is the normal common peroneal nerve. It is a fibular head. And when there is a entrapment, you can see the fibular head over the fibular head, it is more swollen and more big. For injection, you can go either once you identify, you can do the transverse scan and you can go from the lateral to medial. For the foot, I have taken 3-4 blocks which are very, very commonly involved, as the tibial nerve entrapment is a very common, or the tarsal tunnel syndrome is a very common, and patient comes with the medial side of the foot pain, and sometimes they have the shooting pain or paresthesia in the medial ankle and the plantar aspect of the foot. And the tibial nerve entrapment can occur due to the ganglion, lipoma, any accessor musculature, tenosynovitis, or sometimes venous engagement. Sometimes the wrong shoes or they can also cause. And patient, they come with a severe shooting pain of the medial side of the pain. Sometimes scarring and fibrosis of the flexor retinaculum may cause also tarsal tunnel syndrome. In the tarsal tunnel, or the entrapment may occur proximally affecting the tibial nerve, or distally affecting either the medial plantar branch, that is a jogger's foot, or the first branch of the lateral plantar nerve. So here patient is again lateral decubitus position. The affected limb is the lower side because we want to see the medial aspect or medial malleolus. And here is you can use this hockey stick probe, or sometimes the small linear probe also available. You can use that, and you can scan the transverse scan for the tibial nerve injection, and you go from the lateral to medial. So the tarsal tunnel and the tibial nerve. In the tunnel, we have the tibialis posterior tendon, flexor digitorum longus, posterior tibial artery, vein, and nerve. So both the vein, so we always follow VAN, and then the flexor hallucis longus. So tarsal tunnel syndrome it can be a ganglion, varicose veins, lipoma, and this can cause the tarsal tunnel syndrome. So here you can identify tibialis posterior, and then you can inject or you can do hydrodissection of the tibial nerve. So you can again innerve the ganglion, big ganglion, and after that doing, so you can do hydrodissection of the tibial nerve. There's a long axis. If you follow the long axis, then you can go from the caudal to cephalic. Sural nerve entrapment. If patient come with the lateral side of the foot pain, it may be due to the trauma such as the fibular fracture or the iatrogenic injury from the Achilles tendon repair, and sometimes total ankle arthroplasty. The symptoms are again a burning numbness or aching pain at the posterior lateral leg, and you can identify the Achilles tendon, and here is the sural nerve. So patient is the lateral decubitus position, and the foot is you scan the lateral side of the foot and over the lateral malleolus. Tendo-Achilles injection. I remember when few years back the patient came with the bilateral tendo-Achilles rupture. What happened? Patient had the injection of the tendo-Achilles tendon, steroid injection. So that time few surgeons or few doctors, they gave the tendo-Achilles injection, and which can cause actually rupture. I have seen the bilateral tendo-Achilles rupture. So it is, nowadays people don't give, and you should not give, and it is totally contraindicated for any steroid injection for any tendon. And tendo-Achilles is the big tendon for which our whole weight is going on. So, but that is also true. The patients are coming with the tendo-Achilles tendinitis. It's very common tendo-Achilles pain, and patient comes with, and sometimes they don't respond with the conservative management. So we do the tendo-Achilles peritendin PRP treatment. It's actually very superficial and very easy. You should inject even the plantar fascia and the tendo-Achilles. If you inject the superficial to tendon also, they go. So you don't have to go actually whole thing below the tendon. This is the tendo-Achilles. You can go below, or you can go the superficial also. And tendo-Achilles injection is but very painful. Just last week only I have given the tendo-Achilles PRP treatment, and it's really painful injection. So you can see this is the calcaneum, and here is the tendo-Achilles whole thing. Retrocalcaneal bursa. Sometimes this patient, they come with the retrocalcaneum bursa also, and again I will not prefer to give the steroid injection in the retrocalcaneum bursa, because it's a risk. Patient, the injection, the steroid can go in the tendo-Achilles and can cause the rupture. I always prefer for the retrocalcaneum bursa injection also PRP. Here again the same retrocalcaneum bursa, you can inject the PRP. Plantar fascia, this is actually my favorite topic, because before PRP I used to inject the steroid. Even I have injected the steroid I have myself have taken the plantar fascia steroid injection few years back. I had the severe plantar fasciitis. Still I have some plantar fasciitis. So it is a very, very common problem, I think. So, but nowadays when the PRP came and I have started giving the PRP injection, the one injection, it's really so good, and patient after, I don't have to repeat even the plantar fascia PRP injection. So normally, and you can see once you do, first you do the longitudinal scanning, and you can see the plantar fascia. Here is the calcaneum. And if it is a more, you can even diagnose before the injection, once you are doing scanning, if it is the width is the more than 4 millimeter, then it is critical and patient is having the plantar fasciitis. And for injection, then from the longitudinal, you do the transverse scan. Here is the calcaneum, and here you go. So again, for the plantar fasciitis also, you don't have to come all the way to the calcaneum and give the below the fascia. In fact, if you give the above the fascia, it goes itself, and it is a better, because here is also the very painful injection. So always give the local anesthesia before giving the plantar fascia or the retrocalcaneal or tendo-Achilles injection. So here from medial to lateral, you can see the needle, superficial to tendon. Here is the fascia and superficial. You don't have to go deep. Thank you so much. So I don't know, any questions, Debanjali? Hello. I think Debanjali is.
Ma'am, Dr. Debanjali is not in the meeting.
Okay, okay. So thank you very much. Any question is there? So you can, in fact, on everyone's here. So I think there is no question and people are listening. At least it's already 3 hours. It's now 10. Dr. Neeraj, you want to put any comment? Yeah, there are chat 2 questions, I think. Yeah. Plantar. Okay. Thank you. Thank you, Dr. Mittal. Yeah, plantar fasciitis actually is very, very important and very common. And it's very easy also. You can start the knee and foot. They are not very hard, like shoulder. Not very difficult. So thank you, everyone. It's
And
already.
one question is there, like how to select a candidate or how to decide for genicular block oblique RF versus surgery?
Yeah. No, genicular nerve we don't use in the surgery, but for the RF, actually, patient is the grade 2, 3, even the grade 4, which patient, some patient, they are not fit for the surgery and they don't want surgery. In this way, I want to just comment for orthopedic surgeon, for the especially knee replacement surgeon, we are not competitor, we are supplement, because the patients whom they can't do surgery or they can't target or they can't give relief, we can give. So for the genicular nerve RF, you can even take the patients of the grade 3 and grade 4 even. So this is really good treatment for the patients who either not fit for surgery or who they are not. Even the patients, sometimes young patients, they come with the rheumatoid arthritis or other type of the arthritis, they have the severe pain. And at the age of the 50, I don't think the knee replacement is the option, because patient has to live long. So that time also you can give the good relief with the radio frequency. I normally, and I find very good result for with the young patients. I do the PRP with the radio frequency of the genicular.
And ma'am, one more question is there, for early AV and hip, how many session of PRP are needed for results? This
Actually, for AVN early, as Dr. Namita, are you there? Or she left, I think. So for AVN, she said she does the 6 months or in a year, but you can always give the one injection and you find out how patient is doing after 6 weeks and you can repeat. And BMAC is the best option, better option than the PRP for the AVN. And nowadays the kits are available.
That's it, I guess.
See, for the pain reason, you can always do your nerve blocks, you know. So in the meantime, when the PRP and other things, the BMAC is taking its effect, you can at least do the pain work, you know. That is one thing. Second, obviously, you have to repeat. The first injection is not the final injection. So all this degenerative medicine, you might have to do 2-3 injections depending on the response, and that's the best option you have. So this is how it is. About the knee, you know, you gave a very good talk. There's something called IPAC, which is the posterior injection between the popliteal vessels and the knee capsule, and that is very good for posterior knee pain, you know, and it's very much doable with ultrasound only. There's no other way you can do this IPAC injection, because you're very close to the tibial nerve. So that is another very good supplement, you know, you can do this for the posterior knee pain. It's a very, very helpful injection. IPAC is a very, very easy. Easy.
IPAC normally when that surgeon does the surgery, they do. So we can always do.
Yeah, we can always do for pain reasons, you know.
Yes,
That's how it is. And you beautifully said, if we are not competitive, we are helping, supplementing each other. And there would be good number of patients who are older age, who don't want surgery or they are not fit for surgery. There you at least help these patients. You can do all these procedures, at least to make their life comfortable.
There is a question for the plantar fascia. You give the PRP either 1.5 ml maximum or 1 ml, because in plantar fascia you can't inject more. It's really painful and it distant. So 1 to 2 ml is enough for plantar fascia.
Another thing is always when you do all these PRP injections in the area of tissue, you can always calculate the volume with the ultrasound, you know. So it gives you a rough idea of the volume, how much it is going to take, and
Yeah.
you're doing a visualization. You're doing a visualized injection. You're not doing just
Yeah.
just like this. You at least you see the tear is filled or the area is done with. You can just finish with this. You don't even with the PRP. The whole idea is you don't over inject because you can really cause a volume
Cause
tear.
the volume.
Volunteer.
Yes.
So you have to be very, very careful with the volunteer also.
For retrocalculated bursa also, I inject 1 ml. That is enough. I have done the bilateral retrocalculated bursa a few days back, and I have done 1 ml each. So it's very
Always
easy.
tell your
You just
patient it might take a little longer for the response with the PRP than your steroid. Steroid will work in 1 to 2 weeks time, and the PRP will take 2 to 4 weeks time. So patient should be well versed with this. Stop all your anti-inflammatory drugs for the matter, and it's very, very good to supplement with the nerve blocks, because the pain is going to increase for 2 to 4 weeks time. So it's always good to do a nerve blocks along with the PRP. It's much more advisable, to do all these blocks. Not just, just for the time being, so it works for 2 to 4 weeks time. Keep that in mind. So because patient will be in pain for some time. And you're going to stop your NSAIDs for that matter. So that's another reason you should always try.
There
to
is a
do.
one question, Dr. Neeraj. I'm seeing the intratendinous PRP injection for for the collateral ligament tear for the knee. Yeah, you can do.
No,
for the
there's not much of volume. So you cannot do intratendinous. You have to do peritendinous. You
peritendinous.
cannot. There's not much of volume.
Yeah.
You have not much of volume in the collateral ligaments. It's with thin strips around, and you just have to do peritendinous around the tendon, or it should be just in contact the tendon, inside and outside tendon. You don't have to do right inside the tendon.
Inside tendon, yes.
Yeah.
So thank you. I think if anyone has any query, you can talk directly to the faculties. All faculties are well known, and you can directly contact us. And thank you so much. Today we
Dr.
had the
Poddar,
very.
am I allowed to
Yeah,
join in?
please, Sanjay. Thank you so much, and I
Small,
hope.
before you close, small advice to all my friends listening: start taking probe in a hand. Start doing it in normal patients, in normal
Very
circumstances,
important.
for diagnostic reasons. And once you start doing a diagnostic reason, then you get more tuned for the interventions and start putting your needles in there. And when you do doing fluoro work or you're doing blind work, always better to do with the ultrasound guidance. And when you get more expertise with things, you can start taking up more difficult cases and more critical situations also. Like neck is a more critical situation. You can start taking up slowly with time, but adapt early. Be early adapter, because it's going to be there. You will have to take probes in your hand in your theaters. In any case.
Dr. Neeraj, someone is asking, can IPEC be given pre-operatively? Any opinion? I think he.
Yeah, why not? Pre-operatively means for
And
the
how
surgical.
much volume? Yeah, how much
For
volume?
surgical reasons they can, but then you better do all this instead of IPAC. You start doing the sciatic nerve blocks and other things
Yes.
much more proximal, which is much more helpful.
And surgeon
than just an
himself, they
IPAC.
do, na? When they open the knee
Exactly.
and they
You
do.
don't have to do it ourselves. They can do it
Yeah.
on, they open the thing. So you don't have to.
So,
We can go more proximal blocks, rather.
yeah. Sanjay, all
Thank
to
you, Dr. Naveen, for your excellent last parting pearls. The most important thing for a beginner is to take the probe in hand. I think
Yeah.
that is the most important take home message that I have in parts taken from this today's work. On behalf of the society, West Bengal Society for Study of Pain, I thank profusely all the faculty as well as the participants who have listened to the deliberations patiently for almost 3 hours now. And obviously, no words of thanks are enough for Dr. Naveen, such a senior gentleman.
Neeraj. Nah. Sanjay, Neeraj.
I have, sorry.
काम में क्या रखा है, काम में रखा है, never mind.
And Dr. Neeraj को तो कभी भी कोई नहीं है. Everybody knows.
Sir, my apologies, Dr.
No,
Neeraj
please,
Jain,
please,
and-
please. It's okay, my
and-
friend. It's
So thank you very much.
Yeah.
And
Bye-bye.
we
Good
have
night. Good night, friend.
participants from all over, India and outside India also. It's really great. We have on the weekend, and we have the participant of the more than 120. Thank
It's
you
good,
so much.
great, serious learner around. Good one.
And lots of discussion. Almost we have the 94 chat.
By the way, they're good talks, very contentful talks. A lot of content was there.
And thank you so much, Sonosite, for giving us this platform. Thank you. Thank you, Dr. Neeraj.
Good night. Good night.
Good night.
Good night, everybody. Good night.
Yeah, I am ending the meeting. Savita, you can end the meeting.
Sure, ma'am, doing that. Yeah. Good night, ma'am.